Morning.
Doctors, we are live now. You can start the session.
Thank you. Good morning. On behalf of Tnoa, I welcome the stalwarts of the day, the speakers, the moderators, and the management committee members for this Tnoa Connect series, an update in medical and surgical retina in association with Sankar Nethralaya. In line with our President Dr. Mohan Rajan's commandments, initiated during his installation in the month of September 2021, the plan for the year has been a Tnoa Connect series with all institutions of Tamil Nadu, the PG Catalyst series in association with the ARC, and the Walk the Talk series with the luminaries of Tamil Nadu to rejuvenate us and give us new impetus in our practice. We also had the PG quiz competition, ophthalmic photo competition, and also ophthalmic video league. And last month, we had a rejuvenating mid-year meet at Chennai, where we awarded and honored ourselves by honoring the past presidents of Tnoa with Pride of Tnoa Awards. Similar to IPL, we too are having a double header today. We have Tnoa's Gurukulam active for the past from 8 a.m. itself, and now onwards, the Connect series in association with Sankar Nethralaya. We look forward to a wonderful webinar today, and thanks for the opportunity, and thanks to Numerotech and also Hoya for their active participation. And we have a connect, communicate, and consolidate occasion today. Thank you for the opportunity. Dr. Sriram?
Yes, sir. So I think we can go right into the academic session. Rajiv, do you want to take over?
Yeah, thanks, Sriram. Thanks and welcome to the Tnoa Connect series. And today we are covering both aspects, the medical retina and surgical retina. In the medical retina, we have 4 interesting cases, and we have a panel of discussant, Dr. Muna Bhende, Dr. Parveen Sen, Dr. Sriram Gopal, and Dr. Anand Rajendran. And we have 4 cases which will be presented by the consultants from Sankar Nethralaya. And we'll have some good discussion. They're all challenging cases, and we'll definitely have some good learning by the end of that. I would request the first case to be presented by Dr. V. Jayaprakash. He is a consultant vitreoretinal services at Sankar Nethralaya, did his post-graduation from AIIMS, and he'll be sharing his case now. Dr. Jayaprakash, please.
Good morning, everyone. Am I audible? Are my slides visible?
Yes.
Yes.
Thank you. I am Dr. Jayaprakash, and I will be presenting a case of bilateral acute angle closure with asymmetric vascular occlusion. What lies behind? The patient is a 22-year-old lady who came to emergency with complaints of both eyes sudden onset decrease of vision, right eye more than the left eye for the past 1 day. It was associated with headache and vomiting. She gave a history of right-sided headache with occasional vomiting on and off for the past 6 months, which was diagnosed as migraine, and she was on medical treatment for the same. There was no other significant systemic history. On clinical examination, the vitals were stable, general condition was good, there was mild pallor, vision was counting fingers close to face, but she did not cooperate to checking vision with a pinhole. She was orthophoric, extraocular movements were full, free, and painless. There was mild circumcorneal congestion, cornea was clear, angles were shallow, AC was quiet with clear lens in both eyes. There was a right afferent pupillary defect. The intraocular pressures were 40 and 32 millimeters of mercury in the right and left eye respectively. Gonioscopy showed both eyes angles were closed. We could see the right eye fundus even without dilatation, and we could see that the right eye disc was hyperemic. There were a few hemorrhages. The veins were tortuous and dilated. There was intense retinal whitening, but it was patchy. and peripherally we could see that there was this shallow supraciliary effusion. We reviewed a medication and found that she had been started on oral topiramate 25 milligram about 10 days back. And we came to a diagnosis of topiramate-induced secondary acute angle closure glaucoma with peripheral ciliacaudal effusion causing right eye secondary central retinal artery occlusion. So we did immediate ocular massage, tablet acetazolamide, 2 tablets stat were given. Post massage and acetazolamide, IOP came to 32. We gave glycerol, but she did not tolerate the glycerol. So we gave mannitol. And post mannitol, the IOP came down to 22 and 21 millimeters of mercury. When she was comfortable, we could do a UBM, and the AC depth was reduced 1.6 mm approximately. The lens dimensions were approximately normal. There was also 360-degree supraciliary effusion. We did a refraction which showed that the right eye vision was 3/60 and 24, and left eye was 6/9 and 6 with around -6 diopter spherical correction. There was probably an induced myopia. We dilated the left eye and saw the fundus, and the left eye also had venous tortuosity and peripheral retinal whitening. So we asked her to stop the topiramate, continued tablet acetazolamide 3 times a day, started also on Pombigan, atropine, and prednisolone drops, and we asked her to review the next day with a physician opinion. The next day, she told that the vision in the left eye was better. The vision, what we recorded was the same as was post-mannitol. Color vision we could not do in the right eye. Left eye was normal, 17 out of 17. Extraocular movements were full, free, and painless. IOP had come down to 11 and 10. AC had also deepened, and the eye was quiet. However, the fundus examination showed that apart from the venous tortuosity, there were also multiple segmental areas of white lesions in the perivenous area. Normally, in a central retinal artery occlusion, we would expect plaques in the arterioles, but these were seen in the perivenular area. And in addition, you can see that the retinal whitening was not uniform, it was patchy. There is periarteriolar sparring. So the left eye also had venous tortuosity. Apart from that, the posterior pole was normal. The peripheral examination was more significant. In fact, the retinal hemorrhages had increased from what had been seen the previous day, and the perivenular exudation was very evident. There were also areas of intense retinal whitening, which was more in the periphery. In the right eye and the left eye, they were well demarcated, suggestive of left eye choroidal infarct. The OCT showed that the right eye had a cystoid macular edema and shallow subretinal fluid. There was inner retinal hyperreflectivity, but it was patchy. It was not uniform like what you would see in a typical central retinal artery occlusion. Also, the vessels, the veins in the right eye were occluded and did not have the usual figure of 8 configuration which we see on a OCT. So when we saw the patient again on the second day, we were thinking that this is not just a central retinal artery occlusion. I just put a picture of a typical central retinal artery occlusion just for comparison. So the venous tortuosity and the retinal hemorrhages suggest that there is a combined occlusion, both arterial and a venous occlusion. The retinal whitening in the periphery in the right eye would indicate right eye also had peripheral choroidal infarcts. It's very obvious in the left eye, but it's not clear in the right eye because of the overlying retinal vascular occlusion. The periarteriolar sparring would be explained by mesoreal perfusion as described by McLeod. The perivenous sheathing and perivascular retinal hemorrhages suggest that there is probably vasculitis. So the patient had both occlusion and vasculitis both. And the increase in the retinal hemorrhages, we were not sure whether it was because the intraocular pressure was decreased suddenly, there was a decompression retinopathy, or the CRVO was actually progressing. We were not sure of that. Again, in the left eye, there was venous tortuosity, but there's not much hemorrhages. So is there an impending CRVO in the left eye? So anything we should do about it? And again, how can we explain choroidal ischemia in acute angle closure glaucoma? And is there an ophthalmic artery occlusion because of the presence of choroidal infarcts? Again, why is the occlusion asymmetric when both eyes had acute angle closure glaucoma? We are not sure of that. It is not vaccine related because she had taken a vaccination 5 months back. And we were more worried that the headache and vomiting would indicate something more sinister like intracranial vascular thrombosis. We are very much worried about that. So we asked for a complete blood workup, vasculitis workup, physician clearance for IVMP, oral steroids, immunosuppressants to rule out infective foci, a rheumatologist evaluation, corrupted Doppler and cardiologist evaluation, urgent MRI brain and orbit, especially to look at the cerebral venous sinuses. So we were planning for an angiogram, but during this, she also had some breathing difficulty. So we decided not to do an angiogram at this time. The blood reports came the next day. The ESR and CRP were elevated, and she had hypochromic microcytic anemia. The coagulation profile was normal except for prolonged APTT. The LFT proteins and serum globulin were elevated, and the other reports were still awaited. The MRI brain surprisingly showed enhancement of bilateral optic nerve sheath complexes, suggesting possible bilateral optic neuritis. There was also ocular port thickening, and also the lacrimal gland appeared enlarged with adnexal signal. Thankfully, the MR venogram did not show any occlusion, and the brain MRI was normal. Carotid also was normal. The carotid Doppler was also normal. The HRCT chest was also normal. The physician, before giving clearance, asked for a hematologist opinion. So when she came on the 4th day, the patient had worsened. The vision in the right eye, which was counting fingers 3 meter, had dropped to hand movements close to face. The patient had upper lid swelling, ptosis, tenderness, and also temporal chemosis. Extraocular movements were full, but they were painful. In addition, there was an increase in the AC reaction, which was not there earlier. So the fundus picture also was very dramatic. The right eye, there was extensive increase in the retinal hemorrhages. And also the left eye, the choroidal infarct had progressed posteriorly. This was very worrying. And which on this date, which showed mild retinochoroidal elevation, diffuse choroidal thickening, no T sign. So we were worried, why is the eye condition worsening? Is there an increase in ocular ischemia? What is going on behind? We had started her on topical steroids, but still an AC reaction was coming up. So we felt that the patient needed urgent IVMP. Though the labs were still pending, we discussed with the physician and we started the patient on intravenous methylprednisolone and asked her to see hematologist and rheumatologist as early as possible. By the next day, the patient was a little comfortable. The antiphospholipid antibody, both IgG and IgM came positive, and double-stranded DNA antibody and ANA came positive. The other antibodies were negative, and thankfully the infective panel also came negative. So we continued the IVMP for 2 more days and asked her to meet a rheumatologist immediately. So the vision did not improve in the right eye, and the intraocular pressure came down to 6 and 8 millimeters of mercury. At this time point, on the day 6, we stopped acetazolamide, continued her on Combigan, prednisolone, atropine. She was definitely symptomatically better, and the AC reaction also had started coming down. By the 7th day, the right eye had developed breakthrough vitreous hemorrhage. Luckily, in the left eye, the choroidal infarct had not progressed. The investigations have also been repeated by the hematologist, and that also showed raised DSR, LDH elevated, APTT prolongation, Coombs test positive, increased alpha-1 and gamma globulin, ANA double-stranded DNA negative by ELISA but positive by interferon method. Complement C3 was elevated, C4 was decreased. The lupus anticoagulant test was positive. The anticardiolipin antibody, IgG, IgM, and the anti-beta-2 glycoprotein antibody, IgG, IgM, all were positive. So she was triple antibody positive for APLA. So we came to a diagnosis of possible SLE with autoimmune hemolytic anemia with secondary APLA syndrome. Regarding the eye, she had right eye combined occlusion with progressive vasculitis, left eye impending CRVO, both eyes multiple choroidal infarcts with peripheral ciliary infusion, which was probably topiramate induced, which had caused a secondary acute angle closure glaucoma. So we started her on acetrom with INR monitoring. She refused to take rivaroxaban because of the cost. Cardiologist workup turned out to be normal. We gave her an option of rituximab or oral immunosuppression. She preferred to take oral steroids with mycophenolate methadone. We had called the patient to come after a week. Now, topiramate-induced secondary angle closure is well established in the multiple case reports. The mechanism is that there is a ciliary body edema which causes supraciliary effusion and forward rotation of the ciliary body and mechanical angle closure. There is also swelling of the lens which causes a myopic shift, any induced myopia. It does not respond to PI, and pilocarpine is contraindicated and atropine is to be used in these cases. There is a concern regarding use of acetazolamide because the acetazolamide itself has been known to cause secondary acute angle closure because it's also a sulfonamide, but closure activity is very rare, and it is generally agreed that it is safe to use acetazolamide in topiramate-induced secondary acute angle closure glaucoma. Now, to tell that topiramate is what caused the acute angle closure glaucoma, we have to have a temporal relationship, a positive D-challenge, a positive re-challenge, dose-response relationship, biological plausibility, absence of alternative etiology, objective confirmation, and past reports of reaction. In our patient, we cannot do a re-challenge because for obvious reasons, and it occurred within a reasonable time frame of 10 days within starting the topiramate, and it resolved on stopping the topiramate. So we will most probably attribute it as a probable or likely due to topiramate in a particular patient. Now, when going through the literature, we also found that an acute angle closure can be initial presentation of SLE itself, and the pathogenesis is SLE choroidopathy. So in our case, was the acute angle closure due to topiramate or was it the SLE choroidopathy? Most possibly, there was an underlying SLE choroidopathy and it was precipitated by the topiramate and caused an acute angle closure glaucoma. I would like to again highlight that the angle closure, supraciliary diffusion, and choroidal thickening was seen in both eyes. We did not do an angiogram. It would have definitely added more value to know about the choroidopathy. Coming to combined retinal vascular occlusion in the young, SLE leads the list of causes. In combined vascular occlusion, it's first the venous occlusion which happens first, the back pressure which causes the arterial occlusion. SLE ANA is highly sensitive, anti-double stranded DNA is specific, and in the presence of APLA, that is antiphospholipid antibody, there is more risk of vascular occlusion and retinopathy. Various ocular manifestations with SLE have been described. The commonest conjunctivitis sicca. In our patient, probably she had SLE retinopathy and SLE choroidopathy both. How SLE vasculopathy happens is that there is both an intravascular immune deposition, which causes the blockage, and also extravascular permeability and exudation, which causes the constriction of vessels, leading to vascular occlusion. Three types of SLE retinopathy have been described: microangiopathy, which is attributed to hypertension, retinal vasculitis, and venous occlusion. And in our patient, we had vaso-occlusion happening. This is a patient of SLE who came with multiple arterial occlusions. Another patient who presented with Kushner-like retinopathy. There are several case reports on combined arterial and venous occlusion in SLE with and without APLA, but there has not been any case report of the presentation along with the acute angle closure glaucoma. So in our patient, how is the acute angle closure glaucoma related to the combined occlusion? One possible explanation is that there is a two-hit thrombosis. There is an underlying causative factor, that is SLE APLA, and the acute angle closure glaucoma, either because of the topiramate or the SLE choroidopathy, had precipitated it and caused the arterial and venous occlusion. So though the patient did lose vision in one eye, she got to know that she has a systemic condition. So a bad thing has happened, but it ultimately is a good thing that she is on now treatment for the SLE APLA. The learning points from this case is that there was probably underlying SLE choroidopathy, which was precipitated by topiramate and resulted in acute angle closure glaucoma. We could evidently see worsening of ischemia and vasculitis despite controlling IOP, making us think that it was not just a central retinal artery occlusion which we are dealing with. So either the rise or the sudden drop in IOP triggered the frank manifestation of vasculitis. It's important to differentiate the vasculitis from a central retinal artery occlusion. Early identification and prompt treatment is essential, and probably it helped in save the other eye and also helped in treating the systemic condition. However, close follow-up is needed in view of the risk of the neovascular complications in this patient. I would like to thank Dr. Arshi, Dr. Ronak, Dr. Reni, and our SNVR team for helping me with this case. Thank you.
Thanks, Dr. Vijay Prakash. Dr. Anand, what do you feel about this case? This was a very tsunami case. You have seen how the progression happened. What do you feel about this case?
Yeah, first of all, I think I'd like to congratulate Jayaprakash for putting out a fantastic case, so many learning points, and documenting and then discussing it so elaborately. Thank you so much. That was a fantastic case. Absolutely. I think, as he clearly pointed out, I think I'd subscribe to this, two-hit hypothesis. This patient had this underlying APLA syndrome associated with the SLE. And everything that could go wrong did actually go wrong. And both, with APLA, you could have either cardiolipin or the lupus anticoagulant antibody, being positive. In this patient, everything both were positive, and there were more than one antibody which was, came out positive. And the patient also had, unfortunately, this predisposition to the topiramate-induced angle closure. So I think everything went snowballing in that direction. And we had this kind of a very florid outcome in the right eye. And as we saw, the worrying thing was the choroidal infarcts that were happening in the left eye too. And all said and done, it'd be a great save for the patient if one can prevent neovascular glaucoma. If this had not been picked up at the very onset and not suspected and not worked out, one could very well have had the patient, probably presenting later, even with neovascular glaucoma in both eyes. So I think all said and done, at least one eye is kind of preserved. So good job there.
Dr. Parveen, do you feel there were other lab abnormalities which were there, like liver changes were too there, proteins were raised? Are we dealing with a catastrophic APLA? Because they say nowadays that when you have more than two system involvement, that it can be a very, it can be called as CAPS, and that's a life-threatening condition. So when will you decide that you are dealing with something only because patient also had little dizziness on the day one when there was no, so would it be right that immediately internist or a emergency person should see this patient, these type of patients?
Yeah, I think Rajiv, I totally agree with you. And I think if anything, this case highlights, it is the importance of thoroughly investigating a very young patient who comes to you with whether it is a vein occlusion or it is an artery occlusion or the smallest tributary occlusion, because the systemic implications are very high. So this was definitely all three antibodies for APLA. They are all positive, as Anand has mentioned. And I would probably still think that we have some kind of ischemia going around here rather than vasculitis per se. So because some thrombosis at any level, I think a combined thrombosis of maybe ophthalmic artery can give you both choroidal ischemia as well as retinal ischemia. So maybe that is what we are looking at, because there is this whitening, there is not active inflammation of the veins. So I think it is ischemia or thrombosis or occlusive thing which has happened. So probably choroidopathy would have been more, if we are thinking of choroidopathy, it is usually with nephropathy. So we should have investigated for the kidney status as well. But all said and done, this all seems to have unfolded right in front of our eyes, very well managed. And the perils of starting patient on anything, you have migraine, you give topiramide, you have eye pain, you give some other medication. So we have to see the patient as a whole. That is the main learning point from the whole thing, and the team management is what is required. And very well managed, at least we saved one eye. So this probably, I think, FFA was not possible, but FFA ICG would have told us where is the blockage. Sometimes we don't do ICG very often in our occlusive cases, but some of the articles by Dr. Sohan Singh Hare also has been very insightful, and ICG would have picked up the blockage of the choroidal circulation very nicely.
Dr. Sriram, I have one question that we are dealing with a bilateral disease which started with one eye and other eye we were seeing, where we delayed in starting IVMP. Could we have started, because these are the cases, it's always you want to rule out infective causes, but it's a young lady with this type of vasculitis and other things. Could we have started it rather than going through a physician checkup directly of IV with prednisolone? What you feel?
Yeah, that's exactly what was going through my mind, Rajiv, in the initial part of his presentation. IVMP actually would even help topiramate-induced glaucoma. But I think it was a double-edged sword in this case. Imagine if you had started IVMP early, she would have recovered early, and probably the signs which you were able to pick up would have got even more masked. She might have recovered, but you would have still missed a lot of things. So, and the fact that she improved just by intraocular pressure reduction also is a point in favor of the topiramate component playing a big role. So that helped you say that yes, topiramate caused a problem, but then there was something else apart from that. So IVMP was started, yes, but if it had been started earlier, it would have helped her in some ways, but I think it would have made the waters more muddier as well. That's what I feel.
Ma'am, final words from Dr. Muna Pendema about this case.
Yeah, I think this case has a lot of learning points, and probably she is a little young. If she was a little older, a history of multiple abortions may have come up, which is a very common pointer to APLA, especially when you have a young patient with vascular occlusion. That is one simple history you need to ask. And another thing is the first red flag would have been that CRAO at an intraocular pressure of 40 is highly unlikely, especially in a healthy young person, because young people don't manifest so acutely. So I think those are 2 points that, yes, maybe we should have raised the red flag. Yes, I agree, topiramate did play a role, probably aggravating the problem. But at 40 pressure, CRAO is a little unlikely with a young, otherwise healthy person. So I would say that is another point that we need to look at. And yes, it's always at the back of the mind as to whether IVMP had started earlier, but we may have missed the bus as far as diagnosis is concerned.
Thank you. So we'll go. Thanks, Dr. Jayaprakash. Really good
Can
case.
I have one comment
Please.
here, Rajiv?
Please, ma'am.
Yeah. I also agree with Dr. MPB. The initial picture which we see is actually not exactly like CRAO, but I would rather classify it as more like a Portser-like retinopathy. And you have the typical periarteriolar sparing of that area, and then you have these multiple white spots, which is typically like a Portser retinopathy. And it has been described in SLE, which Jayaprakash slide also mentioned. Maybe the initiating factor was a high IOP, which could have led to, with so many of antibodies, maybe it could have led to this some kind of a cytokine storm, and which led to this microvascular occlusion, leading to this kind of a picture. But definitely very intriguing case and very interesting. Thank you.
Rajiv, I have a small query.
Please.
Keeping this vasculitis APL picture out of this, if somebody is presenting, let us say, very high IOP with a combined occlusion, the sort of imminent combined occlusion, reduction in IOP, it will first relieve the CRAO first. So will that itself lead to an increase in hemorrhages? That's what I was thinking.
That's what even he felt, that probably it may be both decompression retinopathy, sudden decompression causing the hemorrhages. That was the one thought which even he had.
Yeah,
I think there was an increase in whitening as well, not just
yes, ma'am. Yes, ma'am. Apart from the vascular inflammatory signs, a sudden increase in hemorrhages can also mean that actually you are on the right path. It may not necessarily mean
that is not so worrying. The worrying part is sudden increase in whitening, because that is visual BCVA implications on BCVA. No, then
more was the other eye, choroidal one.
Other eye choroidal.
Yeah.
Fine. So we'll go to the next case. I would invite Dr. Raja Ganesh. He is a consultant medical retina at Shankar Netralaya, and he'll be sharing another interesting case. Dr. Raja.
Good morning, everyone. I am Dr. Raja Ganesh. Today I'll be presenting a curious case of a forgotten disease. So, this patient is a 52-year-old male who presented with history of night blindness for the past 8 days. And when we inquired more into the history, he gave a history of jaundice for the past 1 week. He was a known alcoholic since many years and was recently diagnosed to have alcoholic liver disease. Though he did not follow the modern medicine treatments, he took homeopathic medicine for 1 day and then stopped it on his own. There is no other known systemic illnesses. On examination, his best corrected visual acuity was 6/7.5 N6 in the right eye and 6/12 N8 in the left eye, and he had a normal color vision in both eyes. Anterior segment examination was normal, except that he had mild icterus in both eyes. Dilated fundus examination was grossly normal. There was no arteriolar attenuation, no disc pallor, no pigmentation, and it was grossly normal. So patient presenting with night blindness, recent onset, 8 days, we had a differential diagnosis as follows, which is melanoma-associated retinopathy or carcinoma-associated retinopathy, drug toxicities, and vitamin A deficiency. Though the patient denied any known recent drug intake, we don't know about the details of the homeopathic medicine that he took. So on investigations, we did a fundus autofluorescence, which was completely normal in both eyes. And visual fields, this was his first fields for the patient. The fields, he had a lot of fixation losses and the field was not much reliable, but he had few non-specific depressed points in the periphery. Then we did an ERG. ERG of the dark adapted 0.01 Hertz showed a non-recordable response, and dark adapted 3 Hertz ERG showed reduced A waves and B waves. And dark adapted 3 Hertz plus oscillatory potential showed the potentials were grossly reduced with a grossly reduced A wave and B waves in the dark adapted 10 Hz ERG also. On light adapted ERG, this was also minimally reduced in both the eyes. So there was grossly reduced combined scotopic and photopic responses, non-recordable scotopic responses, and minimally reduced photopic responses. So then we sent the patient for serum vitamin A assay, which turned out to be low. He had a serum vitamin A of 17 micrograms per deciliter. The normal is 30 to 80 micrograms per deciliter. So with this, we came to a diagnosis of alcoholic liver disease induced vitamin A deficiency with acquired nyctalopia. And the story does not end here. The patient was co-managed with physician and gastroenterologist for the liver disease. He was advised oral vitamin A supplementation, 2 lakh international units on day 1, day 2, and 4 weeks later. And he was also advised 2 lakh international units to be repeated every 6 months until the liver disease is completely cured. Though we had advised everything, the patient was not compliant with the medication. He took the medicines as and when he felt that like he had symptoms. He was not completely following the course as advised. After 3 days, we had a telephonic conversation with the patient, and patient says his symptoms have drastically improved. On follow-up, the patient was called back for follow-up after 2 to 3 months, but the patient did not follow back up. He came back to us after 1 year, during which his jaundice had improved, though not completely cured. His vision has improved, and the patient was completely asymptomatic. At this visit, his best corrected visual acuity was 6/6 N6 in both eyes with a normal color vision. And anterior segment was normal, except that icterus was still present but significantly reduced as compared to the previous visit. Fundus examination was normal, and fundus autofluorescence again, which was repeated, was also normal, same as before. And this is the ERG of the second visit, that is 1 year after follow-up. The dark adapted ERG 0.1 Hz showed a significant improvement in the rod response. This is the present one, and this is the old one. Last time it was non-recordable. This time it has significantly improved. The dark adapted 3 Hz ERG was also significantly improved as compared to the old one. This is the old one, and this is the one on the left is the new one. One on the right is the old one. And the oscillative potentials have also increased significantly with the dark adapted 10 Hz ERG also has increased significant waveforms. And the light adapted ERG has also significantly increased compared to the improved compared to the previous ERGs. At this visit, patient had a normal photopic and scotopic response on ERG. ERG was completely normal. So now comes the twist. Serum vitamin A level was repeated and it was even low as compared to before. This visit patient had 8.98. Previous visit was 17. So serum vitamin A levels have decreased, but patient was symptomatically improved. Patient had significant improvement 3 days after starting serum oral vitamin A supplements, and the ERG has completely improved. But the serum vitamin A levels were even lower as compared to the previous visit. So serum vitamin A level measures free vitamin A. A value less than 14 microgram per deciliter has been identified to cause visual disturbances, though there are reports wherein even higher than this value, patients have had symptoms of night blindness. So the ideal way to measure total body vitamin A is by doing a liver biopsy, which is not done routinely. So the most common method that we use is do a serum vitamin A, which is measuring free vitamin A and does not measure the bound vitamin A. So vitamin A is bound to serum retinol binding protein, which is also synthesized by the liver. So in cases wherein patient has some liver disease like cirrhosis, the serum retinol binding protein can also reduce, which might also play a role in the patients having symptoms of night blindness. There are also studies wherein zinc has been identified to cause vitamin A deficiency because zinc helps in the absorption of vitamin A from the gut. So recovery following vitamin A supplementation can occur as early as 3 days, and near complete recovery can occur in 1 week, and complete recovery can happen in 10 days. So the enigma in our case is patient compliance. Patient did not take the proper prescribed dose of vitamin A as it was advised. Patient was taking it as and when he felt like he had visual symptoms. So that could be one factor which caused the serum vitamin A levels to be low when we repeated after 1 year follow-up, though the symptoms had improved. The another possible hypothesis would be the liver disease and the icterus improved, so which could be supporting for the serum stored vitamin A in the liver, and patients had improvement in the symptoms, but the free vitamin A in serum could have been low. So take-home messages would be ERG is a helpful tool in the follow-up of patients with vitamin A deficiency wherever available. Serum free vitamin A assessment is helpful only in nutritional deficiencies like bowel resection or malnutrition. But in cases like storage disorders where the liver is affected, serum free vitamin A does not correspond to the functional status. And the ideal way to follow up these patients, though the initial diagnosis was based on serum free vitamin A, the follow-up would be better if we were following up the patient with an ERG. Thank you.
Thanks, Dr. Raja. So again, an interesting case. Dr. Sriram, what do you feel about this case? So we routinely look into doing a vitamin A, especially in old age, and you don't have any other things. What do you feel about this case? Any comments?
Yeah, I think it's more of an eye-opener because nowadays we hardly see vitamin A deficiency, given the current scenario. And I think it will come back with more and more other lifestyle diseases because of other systemic problems like this, like alcoholism and liver failure and other things. And only one doubt I had, when you had the second value being lower than the initial value, why not repeat that test again?
Yeah, we can. It was done in the same lab and the same method.
I agree, but
we could have
because
repeated
it's something
it.
which doesn't really correlate. So why not repeat the test again and see whether it was actually accurate? Because it's highly likely either the first or the second test is inaccurate. That was my first thing to think about.
Sure. Dr. Madam, Dr. Munabendra?
Yeah, I think I would agree with Sriram's comments that vitamin A is something that people living on the coastal areas tend not to recognize because we always assume there's enough vitamin A in our diets because we are living on the coast. So, and these patients, it's always important to ask for a history of alcohol intake or liver disease, especially when they present with a recent onset of visual loss. We commonly think of paraneoplastic, we think of CAR, we think of MAR, but asking for alcohol intake, sometimes better to ask the attendant than the patient. And yes, when we get these funny lab reports, to check were we right, and if it is right, then why is it so? And I think that's what is the question for this case. And this is the simple ERG, but they have the red flash also where they do test for patients with suspected vitamin A deficiency. So that's something you would need to ask a patient, ask for when you ask for an ERG.
Dr. Parveen, you would like to add about the ERG part?
Yeah, sure. I think this is something we are seeing more often, and I am seeing quite a bit, especially children coming with this. And the most important few carry-home messages which I have learned seeing these patients is, one is you will have night blindness as a symptom before any dryness. So number two, it is not limited to low socioeconomic status. Because of the dietary fads which we are having, I had a very affluent girl who was having this. Third, as ma'am said, history of alcoholism is again something which you can ask. Fourth, you look at the, this is almost a 50-year-old and you don't have any retinal peripheral RP alterations, granularity, bony spicules, even arterial attenuation. Hardly will there be any genetic underlying pathology in RP which does not present with mild arterial attenuation or fine RP granularity at 50 years of age. So if you are not having these signs and patient is having night blindness and mild constriction of field, you must look for vitamin A deficiency. very important when you look at ERG is that you see that the cone system is relatively preserved as compared to the rod system. And as ma'am said, there is something called the red flash. Without going too much of detail and boring everybody, just one important tip, that the dark adapted response, which is we see combined response, what we call it combined because it is both from the rod and cone. So when you do a red flash, it takes away, it separates the rod and cone. So you can actually identify that this is coming only from cones and it does not come from rods. So again, why this is important? Because genetic diseases, RP always will affect rods and cones. Vitamin A deficiency affects rods selectively. So it helps to differentiate. So these few points. Another point, rapid. So even if you are not able to make a diagnosis, give the required dose of vitamin A. The therapeutic response is so good, as in this case, within days patient response. And when you have already documented such low levels of vitamin A, you cannot have vitamin A toxicity within a week. So it is worthwhile just giving this vitamin A supplement and seeing whether the patient reverses. So the therapeutic challenge itself will be so diagnostic. That's all from me.
Thanks.
Rajiv, one point.
Please, Dr. Balaji.
Balaji, I wanted you to fill in on the diet part.
No. Main thing is actually we have missed the liver function improvement. Actually, the protein binding by the liver would have been much better, and we may be seeing an acute reduction in vitamin A. I mean, at that point of time, because when the liver starts functioning better, the protein synthesis and the binding with the vitamin A may be better. So probably at that point of time, he had a better absorption as well as the binding of the vitamin A, and this could reveal itself in a little bit of a false lowering of it. And the liver improvement might also show be a reason for that. The symptoms of the patient improved, but the amount of vitamin A, free vitamin A in the blood is less actually. And actually, we actually see more of hypervitaminosis A, especially post-COVID, and people are taking fish oils and stuff like that. But we need to keep in, as ma'am said, dietary fats are also there. Vegans and other people who totally avoid animal products may not get vitamin A and vitamin D. They occur together. And people, if they are really vegan, they might not get the protein. Actually, it's not just about the vitamin A alone. We always need the protein to be synthesized to transport it. So these things probably we will elicit in the history, and that is something which we don't have time for. I think which we should be spending more and more time on. Thank you.
Absolutely agree. I think you must realize that vitamin A enters the eye only with a bound form. That is the retinol binding protein and vitamin A together goes. And what you said is probably liver function, and even people do the retinal binding protein RBP values. So that will also give some idea.
Just to fill in, Rajiv, Balaji has done a lot of research in all these diet fads and all their pros and cons. So he's got into all these micronutrients and vitamins and stuff.
Good. Any other comments?
We should have one day with Dr. Balaji.
Yeah.
No, ma'am. Google's call. Google's call.
No, we have a plan of going to all Chennai places and finding it.
Yeah, definitely we should go on.
Sure. So
yeah, just Rajiv, quick comment. Yeah, I agree with what Sriram said. Even that values were a little. That's what hits me first. I think in this particular situation, when you got that low value, I would do serial values, maybe just to see the trend, rather than one shot values. And as Dr. Parmeen said, I just resonate that too. That vitamin A is one thing that you give a challenge, the response is dramatic. Long back in Madurai, I think 20 years back, they had a basin project and study where they found dramatic improvement. And actually, just to on a tangent, vitamin A prophylaxis and that program was probably second to the measles immunization program in terms of value to the community. So just to add that. Also, apart from the list which was put out in the differential, I think one must also look for histories of rarer causes like cystic fibrosis, malabsorption syndromes, even pertussis and whooping cough and all were known to contribute to this in a big way earlier.
One short comment. Just doing a simple OCT will give you an idea what to look for, whether you want to look at a structural defect or a functional defect like a vitamin A, all the RP related cyan pigment and everything, and also the CARMAR and as well as the AR. OCT will not be normal, especially if you look at the peripheral zones, you'll have a loss of PR continuity, photoreceptor continuity. That will give an idea whether how you want to proceed with your investigations. It will be a simple test to guide you on how to move forward.
Sure. I think we'll go to the next case. The next case, I would request Dr. Charanya, C. Charanya. She is a consultant medical retina at Shankar Nethralaya, and she'll be again sharing another case with some good learnings. Charanya, please. You can make it full screen.
Yeah. Good morning, everyone. I'm Dr. Charanya. I'll be presenting on a case presentation. Of a 48-year-old male who came for a routine checkup. He was not a known diabetic or a hypertensive. He had history of hypercholesterolemia since 6 years. His best corrected visual acuity in both eyes was 6/6 and 6. The anterior segment examination and intraocular pressure was within normal limits. On fundus examination, his right eye fundus was normal. On left eye, you can see an abnormal tuft of vessel which was seen supranasal to the macula. So on taking a closer look, we can see there are AV crossing changes seen superior to the disc, and there is this abnormal tuft of dilated vessel seen supranasal to the macula, and there is a communication between an arteriole and venule which is seen nasal to the macula. So what is this abnormal tuft of vessels? So it was initially thought to be a neovascularization. The other differential, is it a collateral or is it a vascular shunt or a malformation? The structural B scan passing through the lesion show that it is an intraretinal lesion with back shadowing and an intact ILM and an intact foveal contour. OCT angiography was done. The right eye OCT angiography was within normal limits, and in the left eye OCT angiogram showed that there is this abnormal tuft of vessel was seen superior nasal to the macula on the superficial capillary plexus. On a closer look, you can see the convoluted and looping and dilated appearance of the vessels. The VR interface and the deep capillary plexus was normal. Fundus fluorescent angiogram was done. It shows there is early arterial filling of the lesion, and in the late phases, there was no leakage seen. And the communication between the arteriole and venule nasal to the macula was also seen on the angiogram. So based on the clinical examination and on the fundus and in the investigations, we came to a diagnosis of a left eye arteriovenous communication of the retina. Based on Archer's classification, this was a group 2 AV malformation. Group 2 is direct arteriovenous communication without a capillary plexus. According to Monso's grading, this is the one infranasal to the macula is a grade 1, which is a direct anastomosis between an arteriole and venule, and the one supranasal to the macula is a grade 2, which is a direct anastomosis between a branch artery and a branch vein. In this case, there was no complications and no systemic features, since we told him to come for a periodical follow-up. The peculiar feature of this case is there are multiple venous connections seen, and the feeding artery continues normally distal to the arteriovenous malformation. So what are arteriovenous malformations? It was first described by Magnus in 1874. It is a direct communication between an artery and a vein without an intervening capillary bed. They are usually rare, congenital, non-hereditary and sporadic. It is usually unilateral and they are high flow system. Usually it is asymptomatic and it is detected on routine examination, and they tend to remain stable and does not affect the visual acuity in like this case. But in some instances like this, there can be associated macular edema, which causes a decrease in the visual acuity. So the other causes of decreased vision, it can, whenever it is located in the macular region, or macular edema, macular and vitreous hemorrhage, retinal venous occlusive disease, retinal ischemia, or a visual field defect due to associated AV malformations and amblyopia can cause a decreased vision. Most common cause of decreased vision is vein occlusion, which occurs in 44%. Usually the arteriovenous communication of the retina can have other systemic associations, most common being central nervous system followed by orbit. Usually 40% are involved in the head region, and usually they are on the same side as the involved eye. In our case, it was thought to be as a neovascularization, but generally arteriovenous malformation should be distinguished from other vascular tumors like a capillary hemangioma, cavernous hemangioma, and vasoproliferative tumors. Usually they are asymptomatic and just will need a periodical follow-up. But if there is exudative maculopathy, then it might need laser photocoagulation or intravitreal anti-VEGF and steroids. Usually laser of sufficient intensity is done to cause vessel crimping. It is done directly on the leaking shunt segment, and it is done over adjacent area of the leaking microvessels. Laser is avoided if the leaking shunt is at or very near to the foveal avascular zone. This is a CAPES report in which a laser is done to prevent recurrent vitreous hemorrhage. You can see that there is a normal vascular network without anomalies following the laser. There are multiple case reports showing there is a decrease in macular edema with anti-VEGF in AV malformation. So this also, anti-VEGF shows a good, cystoid macular edema shows a good response with anti-VEGF. This is an in-house case presentation. In a case of Weber-Mason syndrome associated with retinal artery macroaneurysm, there is a decrease in macular edema following anti-VEGF, and there is an increase in visual acuity. Usually the take-home message is that grade 1 and grade 2 are usually asymptomatic. Grade 3, we need to do MRI to pick up a CNS lesion. It has varied presentation like an asymptomatic one, or it can have complications like macular edema, vein occlusions, macroaneurysms. Not all of them need treatment. Usually FFA complements OCT angiogram in the diagnosis. In this, since it was initially thought to be a neovascularization, we have to keep in mind usually neovascularization doesn't occur in a tributary vein occlusion. Sometimes in an indirect ophthalmoscopy examination, we might miss a small vascular shunt like this. So it is important to do a careful indirect ophthalmoscopy examination along with a slit lamp and 90-day examination. And we have to keep in mind how to differentiate the new vessels from collaterals and vascular shunts. Usually new vessels originate from and contiguous with the pre-existing retinal vascular bed. Collaterals are vessels which develop within the framework of the existing retinal vascular network, and vascular shunts are direct anastomosis between a retinal artery and a vein without a normal capillary bed. New vessels are an exaggerated response to the ischemia, whereas collaterals occur after the occlusion, and vascular shunts can either be congenital or acquired. New vessels are seen as a tuft of irregular, fine, bright red tortuous channels, and they breach the ILM. Collaterals are usually as the same caliber as the vessel it replaces. Vascular shunts are dilated and tortuous. The new vessels usually cause early filling and has leakage on the FFA, whereas collaterals and vascular shunts don't leak on the FFA. This is this you can see irregular vessel sheen nasal to the macula, and on angiogram there is leakage seen, so confirming that it is a new vascularization. Whereas in this you can see that the vessel caliber is similar to the original vessel, and there is no leakage of on the FFA, confirming that it is a collateral. So FFA helps in differentiating all of the three. These are my acknowledgements. Thank you.
Thank you, Serena. Thanks for a nice case. And I think your last slide was the important take-home message, how to differentiate a neovascularization, collateral, and a AV malformation. Dr. Anand, your comments.
Yeah, I think that is a fine case to, instruct all of us, when not to pull the trigger. So it's important. Every time you see something like that, sometimes the initial reaction is to go in and do, suggest a PRP or a sectoral photocoagulation. But I think this is where looking, the second or third point which you mentioned, that should be the first thing that should strike you. Look at the caliber of that malformation /NVE /collateral, and if it is the same as what it as the originator vessels or the vessels from which is coming to proximal and distal, then it should direct your attention to this being possibly an AVM. So I think that is a very important take-home point. And then the advantage, you can leverage the advantage of multimodal imaging. If you have OCT angiography, especially if this happens to be in the posterior pole, sometimes it's in the periphery, it's difficult to do so unless you have wide field. But if you do so, then look at that, look for any ischemic dropout zones, and all this should direct you. Also, if you do not have background features of other ischemic pathology, then that should direct your attention towards these kind of rarer presentations. I think she's discussed the management fairly well. Lasers if required, and anti-VEGF or pharmacotherapy with steroids if there are severe exudative complications. So I think all in all, thank you for
thanks
these pointers. Yeah.
Anybody wants to add anything? I think the last point is also important. Please.
In this case, I think FFA is provides more information than a OCT. OCT will only give limited information. So FFA is sort of mandated to identify the various intricacies of the abnormalities which are present here. And anomalous, these peripapillary arterial loops, when you see these loops are connecting directly to the arteriole, then you know that they are not normal new vessels. So that is and also the OCT, routine OCT, as you showed very nicely, that the presence of vessels were within the retina, not on the surface. So some of the learning points very nicely demonstrated. Thank you.
The peripapillary ones usually present with recurrent vitreous hemorrhages.
Exactly. They can produce CRAO, CRU.
Yeah. So those are the ones which cause repeated vitreum, and then you need to see, and many times that becomes a query what we are dealing with. But I think another important message which she gave is a very important, especially for postgraduates, the tributary vein occlusion, which is something you immediately see the fundus, you feel there is a tributary vein occlusion, but that never causes a new vessel. So I think that is something as a PG they should know, that TRVO will not cause a new vessel formation there. Yeah. Any other points anybody wants to add? Otherwise, we'll go to the last case.
If it's a TRVO, there will be some perfusion related problems.
Correct, Kasi. So I would request the last case, medical retina, the last case, Dr. Janani. She is a consultant VR services at Netralaya. She'll be presenting the case now. Dr. Janani, please.
Good morning, sir. Am I audible and my slides are visible?
Yes.
Yes.
Make it full screen.
Yes. So I'm Dr. Janani Srinivasan, consultant Shankar Netralaya. So I'm presenting a case now. So I'll let you know how we picked it up. So here there was a 28-year-old female. She came to our OPD with a history of wearing glasses since childhood. She gave history of defective vision in the right eye for the past 9 months and in the left eye for the past 1 month. And there was no history of any floaters or flashes. She did give a history of anti-VEGF injections taken elsewhere thrice with suboptimal visual recovery in the right eye. There was no history of any trauma or laser, any previous surgery. So she carried these OCTs which were done outside, which shows a subretinal hyperreflective material, probably a classical CNVM. And we see that the sequential OCTs do not show a great response to anti-VEGF. Then when we looked at her, the BCVA was 624 N10 in the right eye and 624 N12 in the left eye. The refraction was around -16 diopters in the right eye and -14 in the left eye. And IOP was normal, anterior segment was normal, both anterior chamber and vitreous was quiet. So fundus examination of the right eye revealed a clear media with a grayish-white lesion in the fovea with subtle surrounding retinal elevation. And the background retina, we do see multiple punched out chorioretinal atrophic scars, typically clustered around posterior pole or peripapillary location. The corresponding autofluorescent images shows variable autofluorescent at the foveal lesion, and the other lesions are uniformly hypoautofluorescent. In the left eye, the media is again clear, and we see yellowish white creamy lesions with fuzzy borders, and again concentrated at the posterior pole. Corresponding autofluorescence shows foveal lesion to be hypoautofluorescent and the extrafoveal lesion hypoautofluorescent with a hyperautofluorescent ring. So we went ahead with the spectral domain OCT. The foveal lesion, it shows a subretinal hyperreflective material, almost similar to the OCT scans which we saw earlier. And there is no intraretinal cyst or subretinal fluid, whereas the lesion passing through the atrophic scar, it shows atrophy of the outer retina, RPE, as well as the inner choroid, typically punched out with a break in the Brooks membrane. And the spectral domain OCT of the left eye passing through the foveal lesion showed smooth homogeneous RPE elevation. And when we had a closer look, we saw that the RPE elevations, it says that the lesion is involving the sub-RPE area as well as the inner choroid with the break in the Brooks membrane. So we went ahead with the fundus fluorescent angiography and indocyanine angiography. Right eye showed hyperfluorescence corresponding to the CNVM lesion, and which also increased in the late phases. The other atrophic lesions were initially hypofluorescent and late staining. The lesions were uniformly hypofluorescent in the indocyanine angiography. The left eye, which had the active lesions, if we see subtle hyperfluorescent lesion, which increases in intensity in the late phases, and uniformly hypofluorescent in the ICG. So with all these lesions, we had 3 differentials in our mind. One was punctate inner choroidopathy. Second one was multifocal choroiditis and panuveitis, though these 2 diseases are claimed to be of the same spectrum with subtle differences. And third is a myopic CNV. So with the young myopic female in our clinic with scarred CNVM with punched out scars in one eye and yellowish white lesion with fuzzy borders without much inflammation in the left eye. So in light of these findings, we came to a diagnosis of punctate inner choroidopathy. So we went ahead with investigations. Infective panel was negative except for quantiferon TB. However, HRCT chest was normal and chest physician was not in favor of antituberculous therapy, and he gave clearance for oral steroids as well. So we started her with prednisolone 60 mg weekly tapering along with pantoprazole and Shelcal. Anti-VEGF injection in right eye was deferred and it was predominantly scarred. So now we are dealing with the case of scarred CNVM with atrophic scars in the right eye, and in the left eye it is a inflammatory PIC lesions active, and we have managed with immunosuppression. So we saw her 6 weeks later. Since the left eye had active lesions, for want of time, I'm taking the findings of left eye forward. So on fundus examination, these lesions appear more well-defined, more flatter. And in the autofluorescence, the lesions are appearing little smaller, though the two imaging are not really the same mission. And in follow-up, we see spectral domain OCT done through the same area shows that the subtle RP elevations have healed into atrophic lesions, the atrophy involving the outer retina, RP, as well as the inner choroid with the obvious break in the Brooks membrane. So let's review some concept about punctate inner choroidopathy. It is one of the rare white dot syndromes seen in young myopic women, mostly common in white race, and it's 50% bilateral. Typically, the patient presents with unilateral symptom and the physician diagnoses the bilateral disease. Clinical features, most importantly, there is not much anterior chamber or vitreous inflammation. And the active phase, there is yellow-white creamy spots with fuzzy border, typically less than 300 micron size, concentrated in the posterior pole, more typically around the optic disc. And they heal into punched out atrophic scars, which occur pigmentation. The incidence of CNVM is as high as 70%, type 2. And there are three mechanisms of CNV formation. One is endogenous, wherein the CNV forms during the active phase, and bridging type, where the CNVM forms as it bridges the adjacent scars. And third is the sprouting or recurrent CNVM, which happens at the edge of a scar and it keeps on coming back. Subretinal fibrosis is very common, which is the cause for poor prognosis. Pathogens is still unclear, like the other white dot syndromes, could be autoimmune. And there is some papers have discussed that it could be a primary choroidal vasculitis by the ICG findings, which shows the hyperfluorescence along the choroidal vessel walls, along with hypofluorescence also. The hyperfluorescent area corresponding to the choroidal vasculitis and hypofluorescent area corresponding to hypoperfusion. It is important to differentiate between an inflammatory and a neovascular PIC lesion because both appear as hyperreflective RP elevation. If you remember the one which I showed on the right eye, it was irregular heterogeneous RP elevation, whereas on the left eye, it was smooth homogeneous RP elevation. Smooth homogeneous goes more in favor of inflammatory lesion, whereas a heterogeneous irregular lesion goes in favor of a CNVM. So investigations, as I already mentioned, autofluorescence shows hypoautofluorescent with hyperautofluorescent ring. In the late phases, it's uniformly hypoautofluorescent. It is one of the white dot syndromes where we see hyperfluorescence, the early phase of FFA, and ICG shows uniformly hypofluorescence. And OCT staging is there. I will discuss in the subsequent slides. Follow-up we usually do with fundus autofluorescence with OCT, with or without OCTA. If there is no CNVM, usually the lesions are they are self-limited, asymptomatic, and if CNVM develops, patient comes to us mostly in the name of myopic CNVM. That's where we have to know that in a CNVM in a myopic patient could also be due to PIC, and these lesions are very subtle. It is important to keep in mind when we deal with the case of myopic CNVM, because the prognosis also differs, since subretinal fibrosis is very common with PIC. So it means that the prognosis is going to be poor. And though the inflammation is not very recurrent, the CNVM can recur. And treatment in case of active lesions without CNV, we treat with the immunosuppression. CNVM with inflammation, immunosuppression with anti-VEGF, and only CNVM in background of healed lesions, we go with anti-VEGF and PDT. So OCT staging described by Zhang et al. So the initial stage 1, not much OCT changes, subtle hyperreflectivity in the outer nuclear layers, formation of a sub-RP nodule, and then it progresses to the choroidal and choroidal involvement as well as the retinal involvement. And these stage 3 is the typical lesion what we usually encounter as active lesion. When it regresses with the defect in the atrophy involving the outer retina as well as the choroid, with a break in the Brooks membrane and subtle sagging of the retinal layers. And in old lesions, we see complete loss of outer retina with the outer plexiform layers sagging. In our patient, since the first stage is very difficult to identify with OCT, we saw the one lesion which is just inferior to fovea to fit into the stage 2 where there is only sub or P nodule. The typical foveal lesion fitting into stage 3, as I already mentioned. And when it regressed, the follow-up scan was fitting into the stage 4, which is a outer retinal atrophy with subtle sagging of retinal layers. And the right eye atrophic lesion was fitting into this retinal sagging. There is complete loss of outer retina with the sagging of the outer plexiform layers. So we did have an opportunity to go through the all the stages in this patient in both eyes. So to differentiate from multifocal choroiditis, it's important that we remember that it happens in a little older cohorts with prominent anterochamber vitreous inflammation. Lesions are more peripheral and the inflammation recurs and CNVM is much less common compared to the PIC lesion. Although these two diseases are claimed to be part of the same spectrum. And having said that, subretinal fibrosis is also more common in both these diseases. And the other close differential for a myopic CNVM is, for PIC lesion is a myopic CNVM. Here we don't see the typical punched out lesions and the CNVM recurrence in the same area is quite rare and the response to anti-VEGF is good with reasonably better prognosis than a subfoveal PIC lesion. So take home message is that we should remember that punctate inner choroidopathy could be a cause of CNVM in young myopic patient, especially women. And we should look for multiple punched out lesions. Both active lesions can be there in the other eye as well. And we have to differentiate between inflammatory and neovascular PIC lesion as the management options differ. And poor prognosis associated with subretinal fibrosis and subfoveal CNV. And we should follow up the patient closely as the CNVM is known to be recurrent. An article by Spade et al. Said that in their retrospective series, many patients who were initially diagnosed to be a case of myopic CNV were actually found to be PIC. So hence, as a retina physician, we have to remember and think whenever we see a myopic CNVM, whether this could be PIC. My acknowledgements. Thank you.
Thanks, Jenny. Nice case. Dr. Sriram, your comments.
Very nice case, very well worked up. I'd like to ask two things. First thing is, given said and whatever was done, when would you start thinking of PIC when you see a myopic CNV? That's one doubt I had in mind.
Yes, sir. So when
Apart
we see
multiple lesions and just as a take-home message.
So mainly the background lesions, I feel the punched out scars maybe. So the myopic, the chorioretinal atrophic patches are not this type, the typical punched out lesion. So it will be more of a flattish atrophy. So that is one. And in such lesions are seen in both eyes. So that is one.
The myopic CNVM, it's more like more of a generalized atrophy is also there. Yes. And the CNVM is usually solitary. These lesions are usually solitary, one thing. And another thing, the initial fundus picture, at least, barring the pigmentation, the general pattern and distribution of the lesions. One more DD which actually came to my mind was POHS, ocular histoplasmosis.
Yes, sir.
That's another thing which came to my mind. But it's quite uncommon here, I understand.
Yeah,
yes, take of argument.
Formula that is still not available on this machine.
Pardon?
Wherein RX formula outcome analysis.
So
if you implant the toric iron, then if you end up with post-operative refractive error, this is the formula to use.
Sorry, we can't hear this.
We can't hear.
This patient had implanted 16 diameter P5 at 125 degrees.
Is it something else we are hearing?
I don't know. Is the question or is it another webinar?
I think Dr. Mohan Rajan.
Something about 16 diopters implant and all that. I think
Dr. Mohan Rajan is to
cross.
promote himself.
Yeah.
He has recently joined.
I was wondering how did the myopia become
suddenly
from myopia from -4 has become -16 by the end of the talk.
No, the implant was -16.
Refractive surgery. No, he's talking about CNV management. He's talking about refractive surgery.
I think another concept is like.
Hi, Rajiv.
Yeah, please. Yes, sir. Welcome, sir. Welcome. Thank you. Thanks for coming, sir.
Sorry, I'm in a conference in Rajkot.
You told me, sir. You told
Yes,
me.
Manoj Bhatt has organized this for me.
Yes, sir.
I'm in between my talks, so everything is going on well. No.
Yeah. Thanks for joining,
I heard
sir.
Janani's talk. It is very good. Thanks a lot.
Thank you, sir. Thank you, sir.
Thank you, Janani. All the best.
Thank you, sir.
Thanks a lot.
Yeah, one of the thing which I was telling that in whenever there is a CNVM, usually in a uveitic setting, many times we consider it that it is reactivation of uveitis, which may not be a case in PIC. So I think that's something we need to think of. And more recently, people have also started talking, because one of the concept is that if there are breaks in the brook, the myopia progression may reduce. So there are actually now studies going on who are trying to look that if they develop PIC, their myopia progression reduces. I think that's another concept which is coming up. Any other comments by anybody else?
Yeah, Rajiv, if I might just add one, two things. The differential, close differential was, of course, multifocal choroiditis. Just to differentiate between these two, the big punched out lesions are usually smaller, and they're usually within the posterior pole, most often nasal. So that's one thing. And second thing is, usually they have good prognosis, big, but CNVM and subretinal fibrosis can cause, the poorer outcomes. And these cases need to be followed up closely for at least a year, because it's been shown that CNVMs in PIC develop up to a year later. So within a year. So you need to put them, they will respond very quickly. They will look, they will have good vision. So, instead of saying review after 1 year, just be mindful of the fact that within 6 months to 1 year, you can have CNVM developing, especially if those PIC spots are clustered close to the macula. So 1 year follow-up is reasonably tight follow-up is needed.
Very good point.
Rajiv, can I make a point?
Please, Dr. Pal.
Jenny very nicely presented and very good imaging. Just couple of things. There's a recent article which I was going through that I came across in Retina. It has shown like Sri Ram Gopal was asking how do you know that it is CNV underlying or not? So they have spoken of something called the back shadowing. So you spoke of all the things, but if you see one of your OCTs in both eyes, there is a hyper-reflective back shadowing. So if there is an iso-reflective as well as hyper-reflective back shadowing, usually you are dealing with either an active PIC or a scarred PIC. But if you have a hyper-reflective back shadowing, it indicates that the RP elevation could house a CNVM as well, because they say the CNVM becomes very metabolically, or it prevents the light from going down. So it is a hypo. So it just, one more imaging thing. But of course, you could always do an OCTA to see whether there is an underlying CNVM there or not. But very well presented. And it's again, all the cases were such that it opens our eyes that these things can also happen when you look at the patient. Not the first myopia and CNVMs cannot be the only thing. The first thing is that the kind of multilobulated RP elevation that was there, that itself was not very typical of a CNV. It had to be something else than a CNV. Thank you for sharing.
Thank you, ma'am.
Thank you. I'll hand over to Dr. Pramod Phinde. So it was a very nice session, Medical Retina. We had some 4 good cases and a lot of learnings from each one of them. Dr. Pramod Phinde, sir, please.
Just a minute, Rajiv.
Yeah,
thank you.
please,
Thank you so much for wonderfully coordinating this half of the session.
Thanks.
Big thumbs up to you. Thank you, Rajiv.
Yeah, thank you. Let me, good morning, everybody in outset. Let me thank also Sriram and Tnoa for allowing Shankar Netralaya to organize this today's webinar. And again, thanks, Rajiv. Your first half has done extremely well, and hope we'll take things forward. And from Medical Retina, we'll move to Surgical Retina. And the first presentation today will be Dr. Mona. She will be talking. Basically, I won't say this is update. Probably is more like tips about specific surgical procedure, surgical conditions, and all 4 presentations will be like that. And first will be Dr. Mona talking to us about like tips for a scleral buckling surgery. Mona, please take over.
Good afternoon, everyone. And can you see my slides and hear me?
Yes.
So this is my disclaimer, and we'll keep the recent advances for the discussion. I think the first surgical tip in performing scleral buckle is identification of the right case, which requires you to perfect the art of fundus examination with scleral depression and choose appropriate investigational tools if they're indicated. Use the Linkoff's rule to find the primary break. Learn to do a detailed fundus drawing and rule out regions why scleral buckle placement may not be the first option. And these are various factors that may influence your surgical choice. You require time to evaluate your patient and take a history before you decide on these. This is a typical case of a young myopic lady with peripheral lattice degeneration in one eye and temporal retinal detachment in the other eye with peripheral breaks. And this is what we would call a typical case for a scleral buckle. Whereas you need to look a little more carefully when you see a retinal detachment extending to the aura and don't find a break in the periphery. You need to look closer, and near the optic disc here, you see this gentleman, high myope with a small peripapillary break, indicating that this is not the ideal candidate for a scleral buckle. You need to also look beyond the retina. Sometimes most of us tend to forget it. This is a typical young lady with bilateral infratemporal detachments with peripheral lattice degeneration, something we would always think that this is simple buckle. But if you look at the fundus itself, you see these depigmented streaks in the periphery, very obvious in this photograph, but there's almost total lack of RP in this area. And also look at her external appearance. You see the sclera is extremely thin, and this was 360 degrees, indicating that this is not a patient where you would want to put a scleral buckle unless you really had to. Now, this is something where you may opt for a scleral buckle. This young boy presented for a second opinion because he had been advised vitreoretinal surgery with ILM peeling for a rhegmatogenous retinal detachment with a macular hole. And this was his fundus picture. You see this dark red area at the fovea in the left eye. We did an OCT and found that this was just a large cystoid space. This is something very common that you see in patients with a fresh retinal detachment. So an OCT helps. Now, 2 days post scleral buckle, you see that all the intraretinal changes have reversed and the macula is now flat. And 6 months post buckle, the visual acuity improved to 624 and 6. So now we've decided we are going to do a scleral buckle. What are the intraoperative steps that you need to be careful about? Choose your anesthesia, whether you want local anesthesia or general anesthesia. General anesthesia is preferred in young patients and apprehensive patients, patients with tight orbits, or when you plan an extensive scleral buckle. It's important to have good pupillary dilatation to keep the surface moist and the cornea clear. Ensure that there is adequate exposure. Basically, be comfortable. You should be able to rotate the globe and place the buccal element, which is why you need to look at the orbit also. And most importantly, be prepared for surprises. And these could be filtering blebs, leaky cataract sections, scars of previous muscle surgery, radial scleral dehiscence is not clinically obvious, or even scleral reinforcements, because these used to be done for retinitis pigmentosa in the past. So you need to be prepared for these surprises when you plan a case of scleral. Use appropriate visualization techniques, adequate magnification using either a loop or an operating microscope. Have an indirect ophthalmoscope, preferably something that is light, comfortable, and cordless if possible, that doesn't play havoc with your neck. Have enough room in your OR to move around the head end comfortably. You don't need much equipment, so remove all that's unnecessary. And chandeliers we'll use as a point for discussion at the end. However, it's important to note that this may not be either appropriate or economically feasible for every practitioner. Now, the most important tip I would say with exposure of the surgery site is be neat, be generous, and be observant. Make sure you open your conjunctiva and close it as you would like it to be if you were to open it again. Use sharp instruments to separate the Tnoa's capsule. Inspect all scleral quadrants for thinning. Note the vortex veins, and most importantly, avoid damaging the orbital septum during dissection, because a lot of patients can complain about cosmetic defects post-surgery. An important anatomical point to note is that the tenons and conjunctiva is fused for a couple of millimeters from the limbus. So you start opening about 1 or 2 millimeters from the limbus. You make your relaxing cuts here, and then you start spreading your blades now towards the limbus so that it becomes easier to separate the two in a single layer. Here you see how it fuses and how this is visualized and separated. It's important to avoid the obliques while tagging. Pass the muscle hooks around the lateral rectus from above and the superior rectus from the temporal side. This avoids hooking of the inferior oblique and the superior oblique. And keep your eyes and your ears open while handling the muscles. Watch for the oculocardiac reflex, which is manifested by bradycardia, ectopics, nodal rhythm, atrioventricular block, and unfortunately sometimes cardiac arrest. And this is caused by traction on the extraocular muscles, ocular manipulation, and manual pressure on the globe. So what happens if you sense the oculocardiac reflex? Immediately release the pull on the muscle before arrhythmia progresses to silent arrest. Local injection of lidocaine near the eye muscle and intravenous atropine. Prevent it, ensure that the depth of general anesthesia is adequate. Patient should be normocapnic. Your surgical manipulation should be gentle. And if you're using general anesthesia, most of us now give a local anesthetic block after induction. Now, as far as localization of breaks and choosing the buccal site, it's important to know that buccal is all about visualization and correct localization. So localize the lateral limits and the posterior most limit of the breaks and lattices within detached retina. Use either forceps or a cryoprobe. In a bullous RD, beware of parallax. So start moving the indent from the aura posteriorly. Measure distance from the muscle ring with a caliper. It helps you plan your buccal size. And be careful when you're using sharp instruments on the sclera to avoid the vortex veins. And you can get a clue by examining the other eye and look for local landmarks like the vortex exit on the sclera, the vortex ampule, and mirror images in the fellow eye. Two things you need to know about when you do retinopexy is parallax and orientation. Make sure that your cryoprobe is on the break, because when you have an elevated retina, because of parallax, you may have a false posterior localization. Avoid it by sliding the cryoprobe from anterior to posterior. This is another important thing. Make sure you're indenting with the tip and not the shaft. And make sure your cryoprobe is on the sclera and not the lid. So beware of parallax and orientate the position of your cryoprobe. These are my surgical tips for the procedure retinopexy. And when you do apply cryo, don't wait for the ice ball to form in the vitreous cavity. You just see a glow when the freezing starts at the RP level. Maybe a little whitening when it's on the retina. Don't wait for this stage, because this can cause a lot of pigment liberation and sometimes hemorrhage as well. And to minimize cryo, laser can be done on lesions in attached retina. It also reduces the postoperative inflammation. Use your buccal size wisely, but most importantly, beware of the dialysis. We tend to always ensure posterior coverage of the break, very often forgetting that the dialysis at the aura, and commonly postoperative recurrences in dialysis are leaking from the anterior edge. And if you have a small break or a single break, or using a small buccal, you do have an option of a trapdoor or a sutureless buccal supported by tunnels on either side. Now, when you're passing scleral sutures, it's important to know that you're dealing with two curved structures with curves in opposite directions. And once you know this, chances are that there's less likely that you will penetrate. Use a spatulated needle. Introduce the tip slowly. Take the proper depth with a bobbing motion, always under visualization. Make sure the needle tip is visible. and you're less likely to perforate the sclera. Now, these are two techniques that we can use. These are the vertical mattress being used, and you'll see the posterior bites. In the video on your left, you see there will be a large posterior bite taken, which is what you can do to support the buckle. And here there is a single large bite, whereas in the video on the right, you see a modified mattress with two small bites, which is particularly useful when you are dealing with a buckle that you place near the vortex vein. Here, these two small bites help you to avoid passing the suture through the vortex vein. And once you've placed the buckle, an encerclage is optional. You may choose it if you want to support the vitreous base or if there are multiple lesions in attached retina. However, this is an issue that could be open to discussion. But my tip when you use an encerclage along with the scleral buckle is try and place the knot or your Watt's-Guess sleeve over the buckle element, which will minimize knot intrusion, minimize the risk of knot intrusions. Now, to drain or not to drain is always the question. These are the indications where we would drain in most cases. And this is where extremely bullous retinal detachments, where you want to make sure your buckle is on the your break is supported on the buckle, recent intraocular surgery, large breaks, inferior breaks, where not to drain, probably we leave it for the panelists to discuss. The prime drainage sites are above and below the horizontal recti, where you have no vascular element, preferably on the nasal side. And you could use either a cut down or a direct needle perforation or the drainage. The advantage of the cut down is that you can visualize the choroid well and you can cauterize any vessels if necessary and plan a more safe drainage, though it may take a little bit of time. IOP control is important because if the IOP is very high, you can have a choroidal hemorrhage or rapid outflow and retinal and vitreous incarceration, whereas if the IOP is low, there are inadequate drainage, choroidal detachments, and again, suprachoroidal hemorrhages. These are the woes of SRF drainage. At both places, you would want to stop, assess, and treat it appropriately. In a situation where you can get fish mouthing, it's basically the large radial horseshoe tear versus a circumferential buccal element. And very often the horseshoe tear wins and you have fluid leaking from the horseshoe tear across the buccal. And it's usually noticed after very good subretinal fluid drainage and you give a good tightening to adjust the IOP. So readjust IOP, inject fluid or air, and maybe you may need to add a meridional element if the break is not well supported. The finishing touches, never forget to check the optic disc. Ensure the retinal status is satisfactory, all breaks are supported, the buccal height is adequate, and there are no drainage side complications. Optimize the IOP and the buccal height, and you may use any of these methods to do it. Make sure your closure is neat and meticulous in layers. You can use glue as an option. What happens when you tighten the buccal? A moderate indent will give you about 2 diopters of myopia. A very high indent can cause an hourglass configuration and even reduce the axial length, giving you hyperopia. Most importantly, a very high buccal, in addition to looking embarrassing to the surgeon, can also be responsible for recurrent episodes of vitreous hemorrhage due to buccal inclusion. Careful attention to closure. Closure, one would need to close the tenons separately and then close the conjunctiva. Anchor the tenons. Here you see the tenons being separated and anchored in the horizontal meridian before we close, because if you don't close properly, then you can have buttonhole conjunctiva, buccal exposure, and buccal infection. So to conclude, rely on your clinical skills and assessment more than the latest technology. Choose the best, safest, and most economical option for the patient who presents with a detachment. Stick to your comfort zone, but be prepared to innovate when required. My special thanks to the people on the left who responded to my query saying, give me some tips that you learned from me when I supervised your scleral buckle. And most of the tips have been provided by them. And of course, to my department, and thank you for this opportunity.
Thank you very much, Muna. Maybe you can just stop sharing. Yeah. Okay, so we'll go at it one by one. Maybe Dr. Chetan, can you suggest, like inadvertently sometime when we tag the muscles, basically oblique muscle, how we realize that muscles, oblique muscles are tagged and how to get away from it?
So this will happen mostly with the lateral leg tie, and especially if you have not opened your tenons well. So the most important thing is to dissect the tenons very well so that you can see the quadrant in between your lateral and the inferior recti. And I'm talking about the inferior oblique. Yes. Secondly, you will know that the eyeball is not moving well. When you tag a muscle, your eyeball should move freely without any restriction. So if you, especially the best part is the inferior oblique is very well seen. So you can see the fleshy muscle right behind the inferior recti, lateral recti. Now coming to superior oblique, same thing happens when you don't dissect the tenons well from your superior recti. You're bound to pass the suture through the tenons, which covers the sheaths both the superior recti and the oblique. And especially when you go temporally, you'll be able to tag both the oblique as well as the tenons of the tendon of the superior recti. So important thing is to dissect very well. That's what we call quadrant checking. So before we once we do the quadrant checking, we'll know that we have not tagged it properly. When we pull the muscle, we see that there is a restriction in the muscle movement. You should be able to clearly pull the muscle, the globe down. So once you do that, you'll be able to see that. So what you can do is, after you tag the two recti, you pull the muscle down. Good visualization is important, and you try to if you can, either way you can do, either from the nasal side or from the temporal side you can do. You tag it in such a way that you are able to, once you identify the superior recti tendon, go close to the tendon and then lift the tendon and push the thing to the opposite side. You should be able to see your tissue, the muscle hook very well, and dissect. And when you dissect, you should be able to dissect the superior recti. You should lift the superior recti. You'll be able to dissect away the tenons which capsulates both the recti as well as the oblique. And I have always found from temporal to nasal as my preferred technique. You can always go from nasal to temporal as well. But the point is, once you do that, after you tag it, again you have to look back and see whether the recti is free from the oblique sheet. And you'll be able to see the sheet of the oblique very well behind your recti when you pull the recti up. So the sheet of the tenon sheet will be separate from the oblique, and you should be able to see the oblique very well. And when you pull the globe, it should be very freely mobile. So the point is visualization again. So first important tip is to clean the tenons very well. Second is, after you pass the buccal suture, you pull the globe down and see whether there is a restriction of movement. If there's a restriction of movement, you'll have to cut your suture again and then go back to what do you call tagging it again.
Your anatomy well, clean dissection with a good exposure. I think that is what is very, very important. The second question, maybe Dr. Balaji can answer, is now we have a oblique insertion just pans out under the superior rectus, and particularly when you are planning buccal and passing suture there, and sometimes those muscle fibers are obstructing your view, and also passing. How to pass suture in this scenario if you have to go through the muscle fibers?
Sir, I usually use a double muscle hook technique actually. So like Chetan said, the best thing would be to first not hook the fibers and be very sure where you're hooked and reflect the eye down. I usually ask because I would have tagged both the medial as well as the lateral rectus, and I'll ask my assistant to actually pull down the eye and I'll be passing it under the superior rectus. And once I pull it down, I'll be able to see whether the eye is moving vertically up and down freely. If it is not, or I'm having some sort of tagging into it, then definitely I would have been hooking the oblique muscles, and that is very well seen. So at this point, if I'm able to lift the tendon away and I'm able to see the gap very well, I'll pass the muscle hook with the suture. I have a muscle hook with eye, and the initial catch would be by the muscle hook without the eye. So where I'm able to see the space, I will pass the muscle hook with the eye through the under the tendon and go and without catching the oblique fibers and come out, so that I'll be able to tag the superior rectus alone. And mostly I have trouble in superior rectus, and I actually start in the lateral rectus because it's relatively free of the other muscle entrapments at that way.
More what I'm talking about, when you have a fan out muscle there and you have to take suture exactly underneath.
What I would do is I'll try to take a bite on either side and pass the blunt edge through the muscle fibers, especially the oblique muscle. There's an option of disincision and resuturing also, but I don't usually prefer that, a little bit cumbersome. I take one bite on this side, pass the blunt side of the needle through the muscle fibers, and take another bite on the other side of the muscle insertion. That's what I usually do. Probably there'll be some amount of movement disability, but for me, this is much more easier than disincision of the muscle.
We can always take the bites on sides of the muscle, because posterior to the insertion, the sclera is always thin. The risk of perforation is very high. So it's not mandatory. You have to take it in that area. You can take it away also. Sir.
Yeah, that will add extra, but sometimes buckle. Coming to Dr. VTR, Vinata, like when you decide not to drain, and do you give some special instructions to your assistant or your anesthetist when you plan non-drainage?
Yeah, yes, sir. So normally non-drainage, we can plan in patients where, younger patients, where you have the break that is almost opposing to the retina as well as the retina and the retinal pigment epithelium gets opposed easily to the with each other. And the next place is where there is shallow fluid, more anteriorly located breaks, single break, where more of dialysis and shallow RD. These are cases where you can easily get away with non-drainage. And the specific instructions that we normally give is when you're finalizing the buccal, one may need to do multiple times paracentesis. So in accordance to that, you can instruct mannitol to be ready and to be given that time, so that it is easier for us to do 2 or 3 times paracentesis. Also,
yeah, please go ahead. Sorry, go ahead. Sorry.
Also, it is important that if you give a patient bed rest and preoperative positioning, you will be surprised the next day to find a bullous RD settling. So those cases also you can easily get away with a non-drainage.
Dr. Sarvanan, what is your experience using a chandelier while scleral buckling? I know very few people are using.
I don't fancy the only case I have tried was it's a very high myopia, and somehow within it was a very sort of the choroidal and RP degeneration was severe, and there's a loss of contrast, and I could not identify the presence of the break within IDO. So I had to put a chandelier to see through the high magnification of the microscope to identify. That's the only time I have done a chandelier. I am not a proponent of chandelier for buckle. Sorry, sir.
Any one of the panelists have tried chandelier?
Also.
Yeah, because I don't think any one of us really fancy a particular. I'm not, because the moment you put chandelier, I think your extraocular surgery become intraocular as well. And with the chandelier in movement of the globe, sometime again can be a little bit difficult, because chandelier can poke somewhere, and a retina and iatrogenic complex risk of break is always there. Girish, just I have one question for you. When we are dealing with the bullous detachment and draining subretinal fluid, like a lot of fluid is coming. So what we do is, old days also we used to do, and why I'm specifically asking you is something called as controlled drainage. We used to see go back and forth. Can you just elaborate a little bit more on it?
Yeah, so in case of bullous detachments, like what Madam said, sometimes because of the parallax effect, we may not be able to exactly cryo the brake, or the brake cryo may actually fall posterior to the actual location of the brake. So we can do something called as the base technique. That is, you drain first, then you do the air injection to counter the hypotony, then you do the cryo, and then put the encephalage. So the idea is do the drainage in the site where you're going to actually end up putting a explant, and then drain just about enough so that you get the brake to oppose against the retina, so that your cryo is exactly at the point where the brake is going to fall on the RP. And because of the drainage, there will be hypotony. So this is countered by either injecting saline or air. Air also, because sometimes if it's a large brake, saline also can still keep egressing from the brake. So air tends to tamponade the brake itself, and also again given additional internal tamponade. So that's it.
So I think we'll move forward because there are a lot of questions are there, but I think we are short of time. So maybe I'll just invite Dr. Girish for his presentation on tips for proliferative diabetic retinopathy vitrectomy when we do.
So, good afternoon, and thanks to TNOA, Dr. Mohan Rajan and Dr. Sriram for facilitating this symposium. There is a temporal association between the duration and the type of diabetes and the occurrence of proliferative changes, especially during the third decade of the disease, causing blindness in almost 5 to 8% of diabetic patients with the proliferative changes. So this is a busy slide, but I would like you to look only at the histopathologic image, which captures the almost volcanic breakthrough of the neovascularization through the posterior halide phase. So this understanding of the anatomy of the pathology is crucial for us in our surgical success. Vitreous hemorrhage and tractional retinal detachment, especially involving the posterior pole, are among the commonest indications for surgery in a diabetic patient. Type 1 diabetes, treatment-naive proliferative changes, dense vitreous hemorrhage, and bilateral involvement are indications for early surgical intervention in cases of vitreous hemorrhage. Fractional detachments, not all fractional detachments require surgical intervention, but such cases do need close monitoring, as nearly 15% of them would progress on to developing a macular involvement in the first year. And that especially in case where there is persistent activity of the proliferative changes. And so that's why tractional detachment involving the macula becomes an indication for surgical intervention. Besides neovascular glaucoma, combined detachments are an indication for early surgical intervention because the patient has precipitous fall of vision in such cases. And this case, if not tackled early, can progress to an inoperable stage very rapidly. There are many instrumentations which are specifically designed for managing vascular retinopathy. But over the years, advances in the vitrectomy machines and the MIDS systems have helped us in using the modern day cutters, the 27, 25 gauge, 27 gauge cutters with 10K plus cut rates as multifunctional instruments, thus reducing the number of port entries and also reducing the surgical time. But these instruments do have a role in specific conditions. Dyes may be used to highlight the vitreous, the posterior hyaloid, the second membranes, the ilems, and the other membranes on the retinal surface. Tamponade are generally used only in case of regma, which happens either intra or is present preoperatively. One may use various maneuvers in isolation or in combination to remove the fractional elements and flatten the retina, especially the macula. We shall see this in the video presentation. Advances in wide-angle viewing systems have helped us in visualization of the peripheral retina, resulting in better surgical results due to a thorough vitrectomy, membrane dissection, and laser photocoagulations. Probably chandelier does have a role specifically in vascular retinopathies because it facilitates bimanual surgery, which is of great importance while doing membrane dissections. Before we go to the surgical videos, let's look at the role of anti-VEGFs in the preoperative era. Now, this is a meta-analysis of 26 randomized clinical trials encompassing more than 1,800 PDR cases, and which was published in 2020. And they concluded that anti-VEGFs given, especially in the group 6 days to 14 days pre-op, had a better visual acuity and lesser post-op vitreous hemorrhages. What was interesting was that none of the cases where the injections were given at the end of the surgery actually had any benefit, either in terms of visual acuity gain or reducing the intraoperative bleed in such cases. As opposed to the previous slide, which showed that the ideal time of injection, surgery after the injection is maybe 6 days to 14 days. This study, which looked at Avastin, given 5 to 7 days preoperatively, actually concluded that this probably may be the ideal time, resulting in lesser surgical time, lesser instrumentation, lesser intraoperative bleeding, and resulting in a better post-op visual acuity. Equally important to note that this study by Arivalo et al., who looked at anti-VEGF as a treatment for proliferative diabetic retinopathy, found that out of the 211 patients who had this injection as a standalone treatment, 5.2% of them developed, had either development or a progression of their tractional detachment at a mean age of 13 days, and it could range from 3 days to 31 days after an intravitreal injection of bevacizumab. So the timing becomes really important while deciding to give injections in such cases. Now, this is a surgical video which uses the chandelier, and it really is using a 25-gauge vitrectomy system on an NGND, but because of the conversion, I'm just showing you the 2D version of this. So these modern days 25-gauge smaller vitrectomies with high cut rate has enabled us to do confident vitrectomies at high cut rate and at a reasonable vacuum level, very close to the retina. As you can see, this is a case of a combined detachment with very atrophic retina, subretinal gliosis. So what the surgeons attempting to do here is try and induce the posterior detachment hyaloid, and also try and identify the second membrane so that the access to the proliferative tissues is much easier. This can be done either from an outside-in approach, that is from the periphery you come towards the center as you can cut the membranes, or it can also be done as an inside-out approach, where you clear up the area at the posterior pole and close to the optic nerve, and then keep on dissecting this membrane posteriorly. You also have the benefit of controlling the bleeding either by the use of a cautery or by increasing the intraocular pressure just on a foot control. And for the want of time, I'll just try and move this video ahead. It's very important that sometimes you can use the ability of the chandelier, which frees up one arm so that you can use the forceps, either a pick or an end gripping forceps, to hold on to the second membrane or the proliferative front so that the vitreous can be thoroughly cleared up from all sides. And this becomes especially a challenge in a case of combined detachment because the retina also is very mobile. So one needs to try and keep the cut rate and the suction at an optimal level so that there is less of retinal tags. And as is shown here, the forceps helps in stabilizing the membrane, whereas the cutter can actually, in addition to cutting, also actually help us in doing blunt dissection. So as the membranes are separated, because the membrane is not uniformly attached to the retina at all points, except at the points where the vascular proliferative fronds are encroaching onto the retina. This is another video by Dr. Dhanashree, which very beautifully demonstrates the importance of identifying the second membrane. And the instrument that she is using here now is actually a curved scissor. So once she has identified this second membrane, she is using this scissor itself as a membrane forceps and trying to gently roll over this membrane on the retinal surface towards the proliferative frond. And at any point where there is an adhesion, that area is highlighted, and then the scissor is used to cut that proliferative frond. Any bleeding at that point is really minimal because of the crushing effect of the scissors also helps in preventing excessive bleeding. And obviously, a preoperative anti-VEGF in such cases also would actually help in reducing the bleeds during the surgery. And we also have the luxury of a foot-controlled IOP control in such cases. Only caution is when you suddenly raise the pressures to 50 and above, you cannot keep it for a very long time. So you really need to keep an eye on it and get back to the normal intraocular pressures so that the retinal artery perfusion is not compromised. And this actually can be done more safely bimanually, but if you're as dexterous as Dr. Dhanashree, you could actually do it like what she is doing unimanually. So she has a right pipe in the left hand and just using the scissors itself for dissecting this membrane completely and using the scissors to cut the fronds only in very, very sparingly so that the retina is safe. So then the question comes as, does the ILM need a feed? And so actually ILM is almost being treated as an appendix by ophthalmologists. It's been blamed for all the pain and is sacrificed at the drop of the hat. So let's look at some of the studies, this is a randomized controlled trial by Rush et al., which showed that there is definitely a benefit of eyelid peeling during vitrectomy for diabetic teens, resulting in better visual acuity, lesser central macular thickness, lesser risk of ERM formation, and at no additional complications due to the additional step of ILM peel. This is again a study by Zofia et al., who found that there was no additional vision benefit by the ILM peel, but definitely the rate of the central macular thickness reduced, the rate of epiretinal formation, as well as the rate of resurgeries were lesser. This is a Delphi method-based consistent statement, which was published recently in the IJO. And what does it say? That majority of the respondents did opine that they wouldn't peel the ILM if the macula is otherwise normal. In other words, they would restrict the ILM peel only if a surgery was taken up for a specific indication of treating a recalcitrant diabetic macular edema, or after the membrane removal and clearing of the heme, there was an macular pucker or a macular traction. Commonest complications are recurrent vitreous hemorrhage, cataract, and retinal breaks. And this risk of complications is directly proportional to the complexity of the cases. But with proper preoperative evaluation, use of anti-VEGFs, and with the modern day surgical instrumentation, we could obviate most of these complications. In conclusion, the MIBS has resulted in better surgical outcome, a safer procedure, more importantly, better patient comfort, and also has enabled us to take up these cases much earlier before they actually go on to develop tractions and combined detachments. Preoperative anti-VEGF can be used, especially in cases where there is a florid vascular membrane, to reduce the bleeding intraoperative. But this should be given only after the patient has been certified fit for surgery, and then the patient is taken up within 3 to 5 days of the anti-VEGF injections. And ILF wheel may be restricted only for select cases of macular involvement. Thank you.
Thank you very much, Dr. Girish. Nice presentation. Will you stop sharing?
Yes, sir.
Thank you very much. Now, let us start with Dr. Kashinathan. Kashi, the always practical issue, and particularly for beginners, where to initiate dissection. Okay, so can you just have a tips about it?
Yeah. So wherever if the media is clear and you're able to see the fundus, and wherever the hyaloid is lifted, so that's where you need to start your peeling. And say if it's a vitreous hemorrhage, then ultrasound can help you to know where the hyaloid is separated, or a subhyaloid heme also will give you a clue where you have to start your initial vitrectomy. So that's what will help you in planning. And the peeling can always be from the posterior pole to the periphery, or periphery to posterior pole, depending upon each case scenario. But unless we induce the PVD in a regmatogenous RD, we shouldn't do that in a diabetic vitrectomy. We should not do an en bloc PVD lift from the disc, because there will be multiple points of attachments, multiple nails, and it will cause a lot of bleeding. So you have to do a segmental dissection in a diabetic. And these days, cutters are multitask instruments. You can do that with the cutter itself. So the usage of scissors of late has become very, very less.
Yeah, thanks, Kashi. That's very, very important, because initiation is extremely important. Particularly, most of us are taught start from periphery, go towards the center. That is okay, because most of these patients have some amount of posterior hyaloid separation. But lot of cases having a flat PVD, there are practically no PVD and florid probably there you start from center going towards periphery. Yeah, Dr. Vinita, I have a question for you. That do you use anti-VEGF for all the diabetic cases, or you have a select group of cases?
No, sir. They are not used for all the cases. Definitely, when you have vascular proliferation, very much angry-looking vessels, definitely those kind of cases we use. In patients where we cannot see, it's totally vitreous hemorrhage, there we do take a chance and do the surgery without anti-VEGF. But definitely in cases where we have vascular prolif, and that also flat proliferation, extensive posterior pole proliferation, anti-VEGF is definitely used as a tool.
Sometimes I found that sometimes the disadvantage also is anti-VEGF. You have a big flat prolif, vascular prolif, and obviously they're going to have multiple nails of attachment. You give an anti-VEGF here, when you're going to try to pull it, you get some tiny bleeders and sometimes retinal tears also while you're trying to pull this. Yeah, because after an anti-VEGF injection, there's going to be some amount of fibrosis that makes the adhesion sometimes more stronger. And the inadvertent breaks are sometimes a little more.
Thanks for your input, Dr. Kashi. Now, when we are doing a bimanual dissection, Chetan, do you use like a inferotemporal chandelier always, or you decide depending on where to initiate? Not able to hear you, Chetan.
You're muted.
I've rarely used bimanual, but when I use bimanual, just as in case, the case that you showed, I would use it for a combined detachment, which is so extensive that it's virtually impossible to do it unimanually, even if you're using a scissor. So as you said, I would like to look for an area where there is separation of the hyaloid, And I would prefer usually to go from the temporal nasal side and then approach the disc. So from periphery to in is what I usually go. If I find that there is a complete flattening of the polyp up to the periphery, there is no separation from the hyaloid. Otherwise, I mean, I'm sorry, exactly opposite. If there is no separation from the hyaloid from the retina going all toward the periphery, I would probably start from the dissection of the center, because usually you will find some separation in the area of macula, and that's where I'll start dissecting and go towards the periphery. That is where I usually start. If a combined RD is there with the flat polyp, I mean, no separation of the hyaloid and the polyp and the retina, because if going the peripheral retina is usually very thin, and the separation in general, you might find you will develop a break there. So either I start posteriorly or I start nasally.
Yeah, Dr. Sarvanan, when you are dealing with the TRD and you initiate the dissection, now halfway through, suppose you land up in a iatrogenic break. Do you continue same way, or you modify your surgical steps?
When you have iatrogenic break, if you have two scenarios, if you have successfully released the traction around the break, then again I don't shift quadrants, move along in the same quadrants, because continued traction in that area is going to allow the BSS to seep into the subretinal space, making the retina more and more mobile. If I successfully release all the traction around the iatrogenic break, I don't change my direction, move in the same direction. But in case I have residual traction and pulling more is going to induce RD, then I switch over to some other quadrant where the retina is more stiffer and flatter, and then change my direction from other side.
Okay, that's excellent. And the last question for Balaji, like in an era of now MIVS, and because most of the things we are using with doing everything with the cutter, what is the role of scissor in our diabetic surgeries?
It is especially in flat membranes, sir. I don't think cutter is going to work very well, especially when you pull on it. You're going to cause a lot of breaks, and especially if you're going to try and do in these situations, bimanual surgeries really work, and it's very important to learn how to do. Identify the space in between the retina and put in the scissors and try and elevate and cut it. It's always important to keep refreshing your skills with whatever instrumentation is available and never lose it. And one more thing, do it yourself for the chandelier. I don't know if it's relevant in this group. You can, if you do not have a chandelier, you can use old light pipe. Can cut off the end, just expose the filament and put it inside with a 23 gauge needle. It stands very well. If you do not have a chandelier available, or you just need it in a hurry, I think this is something you can try it out.
Thank you for the tips, Dr. Balaji. I think we have to move forward. The next talk will be Dr. Pradeep. He is a senior consultant at Shankar Netralaya, and I think he is one of those people doing a lot of patients with a high myopia and crisis and detachment. Pradeep, please take over.
Good afternoon, everyone. Thanks, sir, and Sriram, Dr. Mohan Rajan, for making Netralaya to be a part of TN academic thing. We'll limit ourselves for the surgical tips specific for the myopic macular hole surgeries. Some of the challenges which are specific for the myopia is the size of the eyeball, which is definitely more than 25 millimeters. Sometimes we see eyeball ranging up to 33 millimeter, where we need to keep in mind the specific modifications we need during the surgery. The presence of posterior staphyloma poses one more challenge in these eyes, and definitely the retinal structural changes, which has a little pathological attachments of the ILM and the retinal surface, poses a little different challenges for us. So all these can be modified broadly into the either changes in our instrumentation or visualization or modifying our surgical techniques. So I thought, let me put it with a tip number 1, 2, 3. The first step when we start the surgery is the selection of the gauge. So the 23 millimeter can reach up to about 29 millimeter of the axial length. So 23 or even 20, sometimes the conventional 20 can also make a good role, especially in the eyes which is ranging up to 33 millimeter of axial length. One can definitely avoid 25 gauges in these because there will be a paradoxical movement when the tip of the instrument and the shaft or the handle what we hold will have a little the movement, especially at the ILM level. The second modification, what we can suggest in these myopic eyes are the posterior sclerotomy, especially on the dominant hand. If you have a right hand dominant, so the hand which holds the flute or the ILM forceps can have a little 4 to 4.5 posterior sclerotomy when you make it. That depends on the left eye or the right eye. The left eye, the nasal, you might have to be a little careful about this. So that can again give a leverage of 1 to 1.5 millimeter in the length of the instruments. The third option would be to take out your troca, which can again give about 2 millimeter extra space for you to directly go from the scleral bed. Coming to the instruments, conventionally, most of the instruments, 23 gauge, what we very importantly use in myopic or macular hole surgeries are the flute or the aspiration needle and the ILM forceps. So these two instruments need to be planned to have a little longer instruments, which are available from DORC in our hospital, no financial interest here. So if you see the normal instruments and these long instruments, especially these two, you have about still 2 millimeter extra. So these are quite rigid as well and can easily make your the posterior cephaloma area reach quite safely and easily. So the tip number 3 would be a visualization. So most of us are with the contact and non-contact lens, and most of us agree that for the ILM peeling, all of us change over to the macular contact lens as well. But I think all of us again experience that when we approach our instruments with this contact lens onto the ILM exactly, and we would not have realized that our instruments are almost 90 degree or completely vertical. So our hands are going to hitch onto these lens and cause an obscuration in the visualization, especially when you have to do a finest, the step which you need to do. So sometimes even the macular lens like this, the Resight one, which you can try to elevate little more beyond the corneal surface and try to get your instruments, the movement vertically so that you don't obscure your visualization. So it's nothing that there is superior contact lens is better or non-contact lens is better. Both can be customized based on the thing. Sometimes very deep 33 millimeter eyeball, you might not be able to do with your contact lens. You might again go back to your non-contact lens also. So the tip number 4, what I wanted to put is the important step of vitrectomy. Most of us agree that the IVT assisted vitrectomy is a part and parcel of any myopic surgery because of the vitreous translucency. And we might have experienced that multiple times we try to induce the PVD from the disc, but we are not able to do so. But we know that the PVD has not been induced. In that case, the tip what we can think is that to look for the mid-peripheral area where you will have a small localized pocketed PVD. And from there, you can insinuate your instruments and try to release the vitreous from the anterior towards the disc posteriorly, and then get a good PVD induction like this. So many a times we all would have done the IVTA, repeated staining one after the other, again to look for the most important, the culprit, that's the vitreoschitic membrane, the last membrane which is onto the surface. So this repeated staining will have to be done, especially to look for that. A meticulous looking surgery, and this is done by Dr. Pramod Bende, and that's how we need to look for I borrowed the video, and we need to look for these translucent membranes over the surface of the retina, which are nothing but the last vitreoschitic membranes. So until you remove that, the success of the closure will not be able to. So you will see a lot of recurrences which might be due to this issue. Coming to the tip number 5, which is an important step or an ILM peeling. ensure that the retina is quite dry after your FG before injecting your dye, because the contact of the dye over the ILM make the contrast little more better, the dyes. And second thing, it might avoid the dye entry into the macular hole and entering into the subretinal space as well. And again, a lot of us would have experienced the negative staining. There will be a patchy staining. Patchy staining sometimes will be helpful because we know that one of the tissue has not been removed completely. Either it can be a vitreoschisis still, that will give us a clue that the vitreous is still adherent in that part of the macula, or it can be an ERM also. So the repeated staining or the negative staining sometimes will help us to ensure that the complete ILM is removed from the macular area. And it's not as easy like what we usually see with, for example, with Dr. Atul Dhawan or Kasinathan playing around the ILM and moving it as like a child's toy. But in myopia, one need to be really careful when we have to, it's such a deep staphyloma, your movement of your instruments can hitch onto the staphyloma borders and cause a sudden bleed or a break in the retina, which we need to be avoided. So a little careful movement circumferentially is important, especially in the deep staphyloma. You would have seen in this video, and sometimes the ILM gets a little more adherent to the blood vessels area. So the quite thick adhesions are there. One need to be careful because you may create a break there, or sometimes a paramacular hole might open up in that area. So the preoperative OCT looking into each area might give us a clue like where is the thickest adhesion of the ILM adjacent to the blood vessels. And not the least that in any myopic macular hole ILM peeling, one need to have a little larger ILM peeling compared to the conventional one, because the retinal elasticity and especially onto the temporal ILM peeling has to be a little more wider. You can try to reach up to the staphyloma borders so that more wider you might have the stretchability and closure of the macular hole more better. The tip number 6, I would like to put it in a detached retina when you need to do an ILM peeling. Here the retina is actually lifted. So you might have to drain some of the subretinal fluid through a drainage retinotomy, which you can make it little adjacent in the macula or paramacular area. And the retina is actually opaque. So paradoxically, you will get your contrast of the ILM much more better than in the attached retina. So the drainage retinotomy helps in these cases to drain the subretinal fluid, or sometimes the subretinal accumulation of the dye, and which you need to repeatedly remove it on and off in order to get a better visualization. And you might land up in removing the fluid directly from the macular hole with a soft tip as well, because that last part of the fluid is definitely difficult to remove at the end of your surgery, and you might have to use the macular hole as well to drain it. The last tip I would like to give is very rarely we come across vitrectomy to be combined with the macular buccal cases. Macular buccal is maybe done for other indication, but an indication where there is a macular buccal along with a vitrectomy, definitely try to prefer the use of a 23 gauge and preferably a valved cannula. Here the surgery steps goes with that macular buccal. You place it first like this, and then go with your vitrectomy. Vitrectomy procedures are as like any other conventional one. So at the end of your ILM peeling and FG, you need to titrate or secure the macular buccal. At this point of time, the globe indentation, especially at the posterior pole, will be little more. So you might have a sudden IOP fluctuation if the valves are not proper. So one need to be very careful in order to avoid this IOP fluctuation, because at that point of time, you might land up with a hemorrhagic oral detachment in these very high myopic eyes. And after the macular buccal, usually the conjunctival closure needs to be a little more meticulous, because you will have a lot of buttonholing. And apart from the 7, Dr. Rajiv had asked me to make it 10, but remaining 3, I can put it with our experienced panelists who can make the other tips more better. Thank you so much.
Thank you very much, Pradeep. So, like rather first question I'll put it is maybe Dr. Saravanan can answer. Yes, we all know ILM peeling is difficult in these eyes. and when have associated macular hole, do you prefer to just peel ILM or use inverted flap?
In myopic holes, especially, and also large first time also, or even recurrent holes, I try to do a inverse flap, or sometimes in the primary cases, the hole is not that very big. I do a temporal flap. So whichever is comes easy to me on table. So either a temporal flap or an inverted flap. And then more than the second recurrence, I go for a retinal graft. I have also tried anterior capsule and posterior capsule. I have not tried amniotic membrane, but there's all a little bit rare case, only 1 or 2 events. So mostly, first attempt temporal flap, the small hole, inverse flap, it's a large hole. Recurrent holes, free flap. Second recurrence, go for a graft.
Another question, maybe I leave open to the panel, anyone can answer. When you are doing a vitrectomy and ILM peeling for schisis, is it necessary to inject gas or oil, or basically internal tamponer, or we can just leave it? Because technically speaking, traction is relieved. I mean, entire panel, anyone can answer this question.
In the absence of a full thickness hole, I don't think it is mandatory to inject any sort of tamponade. If you are afraid that during the process of peeling you have created a hydrogenic breakthrough break, breakthrough hole, then you can try to do. But otherwise, if you are 100% sure that you have no open breaks, through and through breaks, I would not prefer to put a gas or
the question why I asked this one. So, yeah, sorry, please, Kashi, go ahead.
I would prefer to put a short-acting gas, just like in a diabetic, you peel the ILM for some reasons. You put a short-acting gas that will like iron out the posterior pool and give a brief positioning for a couple of days. So I would prefer to give a short-acting gas.
Yeah, Pradeep.
The only concern is that the hole was not there, and the stretching of the retina can create a hydrogenic hole in the postoperative period. Is only one small scale, but both the studies have been done with the tamponade and without the tamponade. Without the tamponade, the only advantage is it takes some time for the retina to settle down back to its position. The hydrogenic hole formation is little rare. It's not so.
Yeah, the plus point for what injecting a tamponade is like a theoretically speaking, because macula flattens quickly, and probably as macula flattens, probably early recovery and maybe visual improvement will be better. Was all of us always thought that longer the macula remain detached, the poorer the functional outcome. But looking at the other side, is this always a chronic situation we are dealing with, and few days waiting, I think, is not going to change the outcome. And probably I also agree, I won't use a tamponade given option if there is no obvious break. So
it's
yeah,
like,
Pradeep.
The two situations. One, if the retina has not been detached from that and it's only the schisis and the thing, so it doesn't have the role of the tamponade in these cases, as long as you don't create any break. If the retina is already lifted from the posterior pole and you don't have a hole, then yes, the tamponade will make the retina flatter faster. And
most of these cases, when you put a gas in the absence of a break, only the fluid tends to get pushed inferiorly because of the superior tamponade effect. The fluid does not absorb fast; it just gets pushed into the lower quadrant. That's what happens.
It's just a macular attachment, faster reattachment of macula.
Yeah. So another question here is when you are planning both options, you have vitrectomy and buccal. In a given case, maybe anyone again can give a tips when to choose vitrectomy and when to choose buccal.
I would always, first choice will be a buccal in a myopic case. If the break is buccalable, it's an anterior located break, and
okay, sorry, please go ahead.
Yeah, and in a young patient, if the break is anterior, yes, buccal is the first choice. And yes, if it's a posterior break, and vitrectomy will be the choice. And a young patient, always try to do a buccal, because inducing PVD in these cases will be difficult and a lot of vitreous schisis will be there. So a lot of hydrogenic problems can happen. And buccal, and always a closed environment is always better to prevent the suprachoroidal hemorrhages in these patients. So that's why valve cannulas are preferred. You should always use a valve cannula, a new set of cannulas when you do a myopic vitrectomies.
Dr. Balaji, just last question on this topic. Like quite sometime when you're doing vitrectomy, we know we're probably able to induce PVD sometime going beyond the arcade, and after that you get stuck. Just sorry, Balaji is not there.
Dr.
Maybe
Balaji
then,
is just left for another commitment.
sorry. So Sarvanan can answer this question, and then Pradeep maybe add on some tips.
You have to make a difference between whether it's a very sticky vitreous or whether you have a posterior migration of the vitreous base. Sometimes in syndromic arteries, you have this that a very wide vitreous base where the vitreous cannot be peeled beyond for a certain extent. Suppose you have a superior break and you are very vigorous in your peeling, then you can produce unnecessary iatrogenic breaks in the inferior quadrant also. So once you are sure that it is a posteriorly migrated vitreous base, better to leave it as it is and trim off the above peripheral vitreous rather than trying to strip it. Just trimming with cutter, either interface vitrectomy using air or TFCL and trying to stabilize the retina and doing a little bit of close shaving. That is what I usually prefer.
Sometimes in this case, you can leave a bell buckle. If you are not unable to shave the vitreous anteriorly, you can put a prophylactic bell buckle.
Yeah.
So I think thank you very much. I think this will move forward. Next talk will be Dr. Dhanashri. She is going to give us tips as per the scleral fixation IOLs.
Thank you for this kind invitation. So I am going to talk to you. Good afternoon, everyone. And I understand that it's very late and all of you must be really hungry. So I won't take much time. So I'm going to talk to you about the tips and tricks for successful scleral fixated intraocular lens surgery. So they say that everyone learns from their mistakes, but intelligent people are those who learn from others' mistakes. So these are probably my mistakes, and what I learned will hopefully help you in fine-tuning your technique. So this scleral fixated IOL is probably the single most surgical procedure which has been tried by many variations. There are innumerable surgeons have reported innumerable variations of this scleral fixation. So regardless of whatever technique you follow or whatever variation you use, there are some general principles which hold true for all, and they have to be followed to have a successful surgery. But there are slight variations between sutured scleral fixated IOLs and sutureless. So first I will talk about my 10 tips for sutured scleral fixated IOLs. So the first single most important tip is that mark the fixation sites well. So this is the most important because this is what is going to give you success of surgery. The lens is going to be stabilized and you will have a good outcome. So generally the fixation sites are chosen at 3 and 9 o'clock meridians. And most important is that they should be exactly 180 degrees apart. So mark the cornea and the limbus well. You can use a RK marker or you can use any other marker which you wish. But mark the sides which are exactly 180 degrees apart like this. So this avoids tilt or torque or astigmatism and gives you a good outcome. So as I said, generally 3 and 9 o'clocks are the ones which are preferred sites. But sometimes you may have to shift the scleral fixation sites, especially if there is a prior trauma or a scarring due to previous surgeries or presence of filtering blebs. Then these dictate the placement of scleral flaps. So when you are shifting the scleral flaps, generally you shift in the superonasal and inferotemporal quadrant for the ease of manipulation and in these quadrants. If you shift to inferonasal, then it's a little difficult to manipulate in this quadrant. But make sure that you maintain the 180 degree alignment. That is the fixation. The two sides for fixation are exactly 180 degree apart. And in this situation where you have combined surgery or previous scarring, plan your incisions or your sclerotomies and all the suture entries, everything you must plan methodically so that you have a successful outcome. Also, you can either do scleral flaps or scleral pockets, but measure the dimensions for the flaps on the pockets so that you don't end up with either too large or too small flaps. And the flaps or the pockets should not be either too thin or too thick. So this is again one important tip. Tip number 3 is that measure all the entry points. So these are I am making these trocar entries on both these sides. You can either have a 4-point fixation or 2-point fixation. Generally, a 4-point fixation is more stable than 2-point. So initially, I would suggest that you make flaps instead of pockets, and under the flaps, mark these entry points. I generally prefer to use this marking. I use 1 millimeter on either side of the central mark and about 2 millimeters from the limbus. But it is better to put the IOL a little bit more posteriorly to avoid iris shaping and glaucoma and pigment release, etc. So some people even prefer 2.5 millimeters. Number 4 tip is do a complete vitrectomy. This is very important because if you leave a lot of vitreous behind, the higher the chances of having a late post-operative complications such as peripheral retinal breaks or sometimes even a giant retinal tear, etc. can happen. So make sure that you do core vitrectomy, do PVD induction and do as thorough vitrectomy as you can. PVD induction can be a little difficult because these are young patients. Many of them are young children and sometimes it might be very difficult, but spend enough time in inducing the PVD. With perseverance, you might be able to induce PVD and do a good vitrectomy. At the same time, make sure that you also clear the 3 and 9 o'clock meridians where you are going to fix the sutures, because this will avoid entanglement of the sutures and the haptics of the intraocular lens. And it will also prevent traction on the vitreous base because the number of passes that you make through this area will every time will push the vitreous if it is there. So if you remove the vitreous, that will again help in better outcome. Number 6 tip is that treat all peripheral lesions. Very often a preoperative fundus evaluation is difficult in these patients because of either trauma or because of subluxated lens. And if you find any peripheral lesions, I mean, always inspect the periphery of the retina after you have done the vitrectomy. And if you do find any peripheral lesions, then treat them with laser so that you have less chance of any postoperative or late postoperative retinal detachment. Number 7, the tip is that be very careful about entanglement of the sutures. Now this is very less with Vortex because Vortex is a very thick and very easily visible suture. But if you are using Prolene such as a Tnoa, then the Vortex it can get entangled. So be very careful. It helps to follow a set routine while passing the sutures. So I generally pass the distal suture first and also the left hand side first, and then I pass the proximal suture first. But whatever routine you wish, you can follow, but it helps to have the same routine for each and every surgery so that you know which suture belongs to which side, which is distal, which is proximal, and there is less confusion and less entanglement. If the sutures get entangled, then you may have to redo the whole surgery. So again, that is a problematic case. Number 8 tip is that leave the while you are trimming the sutures after tying the intraocular lens, you leave the suture ends long, especially for Prolene, so that they don't poke through the scleral flap and the conjunctiva and they can lie flat on the sclera. For Vortex, it is much easier because Vortex is already a very flat suture. And try and bury the knots in the trocar entries or the needle entries that you have made. However, I am not very aggressive in doing that because once or twice when I was using a Prolene suture, while burying the knot, the suture broke. And then that's again a nightmare because then again you have to redo the whole thing. So I generally try to bury a little bit. If it can bury it, fine. Otherwise, I can just leave it. And that is the reason why the flaps or the pockets are very useful in this situation. Number 9, that when you are making the scleral tunnel to pass the intraocular lens, make sure that you make an adequate size tunnel. Here the scleral, of course, it will depend on the size of the intraocular lens that you are using. So the normal scleral fixated intraocular lens which you use is a rigid non-foldable lens with some 2 eyelets on the side, which is a large lens. And I make about 7 millimeters length of the scleral tunnel. Now, once you have the sutures in place, it is difficult to enlarge the tunnel. Sometimes you may cut the suture. So in the beginning itself, make adequate size tunnel so that you don't have any difficulty in passing the lens or the sutures through the tunnel. And number 10, this is the last tip, that we respect the conjunctiva. Be careful about the conjunctival opening as well as conjunctival closure. So conjunctival closure is equally important. Make sure that when you close the conjunctiva, there is neither overriding nor retraction of the conjunctiva, and it sits well at the limbus without causing any heaping at the limbus. So these are my 10 tips for the sutured SF-IOLs and some few tips for the sutureless SF-IOLs. So I don't do the sutureless SF-IOLs since I am very comfortable with the sutured one. And I thank Dr. Girish and Dr. Kaustubh for giving me these images. So number 1 tip is again mark all the entry points. So either if you are doing a glued IOL or if you are doing even Yamane technique, the entry points of the needles and the scleral tunnels all should be marked very well. So here you can see in the schematic drawing, the scleral flap and this 2-point needle entries are marked, and also make sure the scleral tunnel that you are going to do on both the sides are also of equal length. So the more precise you are in this, it will help you in having a better well-centered intraocular lens. Since this is a 2-point fixation, sometimes there can be a possibility of tilt. So to avoid that, it is important that you follow these tips. Second important tip is that choose the most appropriate intraocular lens for this technique. So not all intraocular lenses are amenable for this kind of scleral fixation. And the ideal one is the CT Lucia 602, which is made by the Carl Zeiss Meditech company. I don't know whether it is available or not, but Dr. Girish, I think he uses the 3-piece Acrisoft foldable lens. Make sure that this IOL has a PVDF haptics. So these haptics are resistant to kinking and breakage. So you would have sometimes if you are doing this manipulation with the haptics and the haptics get deformed, then that would lead to decentration or tilting of the lens. So it is better to use a correct IOL. Number 3 is maintain intraocular pressure while you are doing the procedure. So some of these scleral fixated IOLs are done by the anterior segment surgeons, and they may not have an infusion cannula going on, infusing fluid inside the posterior segment. But it is advisable to have some infusion inside. Either you can have an AC maintainer, because if you are trying to do this needle entries in the hypotenuse globe, it is difficult. You may not have the correct point of entry, and there is also chances of having intraocular injury is higher if you have an hypotenuse eye. So make sure that the eye is well formed. Either inject viscoelastic or have an infusion inside. And the last tip is that make sure that the trailing haptic is threaded carefully into the needle. This, I believe, is the most difficult step in this kind of glued IOL or the Yamane technique. And so instead of trying to juggle this inside the intraocularly in the anterior chamber, it is preferable to put the needle outside through the scleral tunnel and then tuck this haptic into thread this haptic into the bore of the needle outside the eye, and then pull the needle inside. So this way, you have to fight less with this haptic. So it is equally important to know what not to do when you are doing scleral fixated IOL. So please avoid SF IOL in children below 6 years of age, because the eye is not still mature, the pars plana is not mature, and you may have refractive surprises as the child grows up. So avoid in young children. Similarly, avoid SF IOL in eyes that have got very short or very long axial length. So highly hyperopic or highly myopic eyes should be avoided. Again, because the anatomy is not good, the pars plana is not well formed, the pars plicatas, etc. And also you will have again refractive surprises. Similarly, avoid scleral fixated IOL in eyes which have got malformed anterior segment, either due to trauma or due to anterior staphyloma or due to coloboma, etc. Also avoid SF-IOL in eyes which have got scleral thinning, especially patients with collagen vascular diseases such as Ehlers-Danlos, etc. And while if you are using a tenoproline suture, then do not exert too much tension while you are tightening the sutures, because this tenoproline is quite a delicate suture and it can break easily. And if it breaks at this stage, then as I said, you have to redo the whole procedure. So be careful while you are using a tenoproline. But if you follow these some few tips, the scleral fixated IOL can be made ridiculously simple, and I'm sure you will realize that. So thank you very much for this opportunity and for your kind attention.
Thank you very much, Dhanashri. Maybe just we'll start with Dr. Kasinathan. Dr. Kasi, do you have a choice of IOL when you decide for SF IOL?
SF IOL, now I do only this glued IOL techniques. And SF 3-piece IOL, what I normally prefer now is, I don't prefer the Alcon IOL because the haptics are little longer and sometimes they break during the manipulation. I am particularly comfortable with it. Now the Aravind has the 3-piece foldable and preloaded IOLs. So nowadays I use the multi-piece preloaded IOL from Aravind, and that I'm very comfortable, and that goes exactly like without any sutures. So it goes through the 2.2 millimeters corneal tunnel itself. So nowadays I prefer that.
Is Dr. Sarvanan now intraoperatively during surgery, suppose you land up in a iatrogenic problem and you need to add a tamponade. Other peripheral lesion, Dr. Dhanaji says we can just laser and go ahead with complete your procedure intraoperatively or preoperatively if you identify lesion. But suppose you land up in a break or localized detachment, now you need to use tamponade. Do you continue with the SFI or you abandon the procedure, do it as a second sitting? What is
I
your
usually
choice?
try to do both together. I had one case, similar scenario, two scenarios. One was somebody else was an anti-segment was surgeon was doing, and he had a GRT intraoperatively. But he had already placed the lens, so without removing the lens, I did the surgery. The only trouble is that when you are going for a fluid air exchange, what happens is that there will be a lot of condensation and the air can come into the antechamber, thereby sort of compromising your visualization. So that is one of the troubles when you are having a SF fiber. Another case, it was the patient came for surgery after 4 or 5 days after advising. By the time he had come, he had developed RDB where the macula was still attached. It was more of a temporal RD. Both instances, I didn't skip the SFIL step. I did the SFIL and then went on with the retinal surgery also.
One currently available is from our SN Alumini Nivian. He has made a CMT flex lens, which is again a foldable hydrophilic lens. It again goes through 2.2 and it is a nicely designed lens where you don't need to put any stitches or anything or glue. You just have to hook it up and you don't need to tuck the haptics also. That's a nice lens. Off late I've started using it. Only thing, maybe the learning curve, I started breaking the haptics. But I think that's a good lens off late.
I think Girish also has a good experience using like a non-suture. Any tips, Girish, you add on here?
I think Ganesh has covered most of it. So definitely, I have used both the Alcon, the AMO, as well as the Arwen lenses, the Aurolab lenses. And my only point was with the AMO, the present J&J lenses, the techniques or the sensor, the haptics tend to break. I've never had any breakage with the Alcon, though while, as Dhanesh said, while we are trying to manipulate the second haptic into the bore of the needle, there is always a risk of inadvertent pressing of the haptic too much and it could bend. But otherwise, I've never had a breakage.
Chetan, in a sutured IOL, when we are passing the suture, do you have any specific tips so that you can minimize the tilt or torsion of the lens?
Sir, I think, sir, what Madam has clear is the positioning of the your entries into the eye, which is very important. It has to be equidistant from the limbus. It has to be on both sides and also equidistant from the marking points, so that you don't really. And secondly, you don't, when you finalize your sutures, you should not finalize sutures in a hypotenuse eye. So infusion should be on, your section should be closed, everything should be tight, as you would expect at the in a normal physiological condition. You should not be tightening the suture when there is leakage. So you ensure that all your sections are closed. If you want to take sutures through your sections, fine. You want to close your sclerotomies, fine. But keep the infusion for your last, so that you can modify. You can what do you call your IOP according to, just keep a normal tight globe and then finalize the suture. That should be the last step. Should be removing your cannulas, whether you keep an AC maintainer or whether you keep a infusion cannula. So that is important. So equidistance, all should be same distance from the limbus or same distance from your center points, and all sections should be closed for a normal stable IOP before you finalize your sutures.
Dr. Pramod, if I may add a point.
Please, please.
Yeah, so one often the learning curve is the breakage of the haptics. When you hold that haptic tip and insert into the scleral tunnels. So what I've done is a slight modification where I actually make it a little triangular. If you can imagine a right angle triangle with the right angle at the limbus and pointing towards the limbus. And so the entry point is a little wide and the tunnel tapers down towards the end. So this allows entry, you can, your forceps which you're holding, you have to use a curved gabor forceps to hold that and then insert into the tunnel, so that that entry point allows for the inserting forces, which is I prefer the back person to and as you push the haptic into that, the groove actually the groove is actually tapering down. So then it holds that haptic, and this prevents breakage as well as a secure haptic insertion.
You use 27 or 30 gauge needle?
Which one?
For externalization of haptic.
They use the max grip forces rather than the needle, like other than what they showed with the Yamanes. I use the max grip Alcon forces.
Okay. Yeah. Okay.
Can
So
I
I
add a
think.
couple of points, sir?
Sure.
No, sir. Between 27 and 30, if you're doing a skill flap and stuff, I think it's okay to use a 27. But if you're doing a transconjunctival Yamane, 30 works much better because track which is going through the sclera and ciliary body is much thinner. That's when you are able to deform the haptic and push it in. 1 point. So 30, but not the regular 30 we use for intravit injections. Those are very small bores and the haptic will not enter. You try to push your haptic, that's when you get breakage. You need to use special thin wall 30 gauge needles. And second thing is regarding the haptics, the Orolab haptics, yeah, the lens is good. The problem is that haptics is almost a J-shaped haptic. So if you're using the Orolab lenses, you need to necessarily, after you externalize, you need to trim off the haptics a little bit before you deform it and push it in. Otherwise, you start pushing out again after a few months.
I trim the haptics, usually trim it and then push it inside.
How you decide how much to trim, because that's become little bit relative things. That's a little tricky situation.
Yeah.
I trim 1 mm, sir. I use a caliper measure and trim 1 mm.
So I do it in a thumb
I've
rule.
learned it by trial and error.
So I do it by thumb rule. I see how much intrascleral that tunnel I made with my needle. Accordingly, I'll just trim it, sir. So the lens has to be stable. Some part of the tip has to be in the intrascleral tunnel for stability. That's it.
Sir, if I may have a point here.
Yes, please.
I think my only concern about cutting the haptics is the normal haptic which is made is rounded. Whereas when you cut it, it is sharp. So over a period of time, it can still erode through the sclera and the conjunctiva. So one needs to be a little careful of that.
Yeah, but in Yamane, you deform it again with cautery, so it becomes sort of bulbous.
Yeah.
The moment you use cautery, it becomes bulbous.
You do the Yamane with the Orolab lenses?
Yes, sir. Yes.
Okay. Okay.
My
I'll do it
concern
either
is
with Orolab or with Sensor 3, sir.
Yeah.
My concern is that you are already stretching this haptic, which is the IOL, which is supposed to be the ciliary sulcus 12.5 or 13.5. You are already stretching the haptics way beyond 14-15 millimeters. And then if you further trim the haptics, you are again increasing the stretch on the IOL. So I am not sure in the long run how that stretch or the stress which is exerted on the haptic optic junction, how it is going to pan out, say 10-20 years down the line.
But these haptics, they are much more redundant. It doesn't stop like a C. It comes and curves around. So if you see those haptics, you'll realize it actually comes and curves around like more of a J rather than a C.
I think, thank you very much for all, and thank all the speakers and panelists. I think that we can go on, and I'm sure a lot of questions I missed because of time factor. We have to stop some or other way. And thank you once again, Tnoa, and specifically Sriram for coordinating everything, all the panelists and speakers. Sriram, back to you.
Yes, sir. Thank you, sir. Thank you so much. I played a very small part, so I'll begin with saying that. Thank you, Dr. Pramod Bende, and thank you, Dr. Rajiv Raman, for wonderfully coordinating 2 distinct sessions across almost 2.5 hours. Big thanks to all the speakers and panelists who devoted probably the entire Sunday half a day towards such a good session. I'm sure everybody who attended was very this thing. Thanks to our president, Dr. Mohan Rajan, and big thanks to the team of Numerotech who ensured such a seamless delivery of this session without any glitches. Thank you, one and all.
Thank you.
Thank you. Can you switch on everybody? Can you switch on everybody to just take one photograph, please? Video on, please, everybody.
Kasi video.
Kasi doesn't want to.
Kasi was sleeping.
No still photographs.
Janani, Saranya. Janani, Saranya. They are still.
Hey, where is Balaji? Sriram.
Balaji as usual.
Balaji is left.
He's always the last minute plan ditcher.
Saranya, please switch on your video if she's there.
Somebody can call her.
maybe I think just we miss her anyway. So thank you very much once again.
Happy weekend. Bye.
Okay.
Thank you, sir. Thank you so much.
Enjoy leftover Sunday, please.
The rest of the Sunday, sir.
Lunch at respective homes, variety of menu.
Okay.
Okay, bye.
She's come, sir. Dr. Saranya has come.
Oh, Saranya, yes,
Yeah,
she is there.
Yeah.
Mhm. Thank you very much, one and all.
Bye-bye.
Bye. Bye.
Thank you, sir. Thank you.